under this month, which is a prostate cancer awareness month, and we have made a 2-day prostate masterclass over this topic. I welcome you all. A vast galaxy of speakers, panelists, and chairpersons are there. So, with the permission, we start these proceedings, and I would request Dr. Rajiv Sood, sir, who is the president of Genitourinary Cancer Society of India, the president of Delhi Urological Society, the secretary of Andrology India, and the chairman of Indian School of Urology, to welcome the delegates and give an opening remark. Sood, sir. Good evening.
Good evening, everybody. This is a great evening today in the Prostate Awareness Month, which we are having the stalwarts like Professor N.P. Gupta is there, who actually coined the word Prostate Disease Awareness Program in India, and ultimately we settled for it through Urological Society of India. And I was fortunate enough that USI at that time had made me national convener. We started all this in 2007, and we were not very much behind USA, Europe, or UK, to say few countries who had started 1999, 2001 in Europe, and then it was 2003 when it was taken up in USA after President proclamation. And it was declared the whole month. The first week is for prostate awareness, the awareness activities. The second week was the observance, that was for prostatitis. And third week, which is going to come, that is for the prostate cancer. And the fourth week is for the benign prostate hyperplasia. We had conducted several camps, and we created the national network for this. And after that, this has taken up. Hello. Professor P. Venugopal is with us, and the patron Dr. G.K. Rath, who has done a lot of work in cancer registry, and also motivated people to collect the data and epidemiological studies which are going on. The USI is also now chipping in by their data management cell. So all the activities are going on. We are thankful to all the societies, especially Urological Society of India, and then USI, Kochi onward, has coordinated and as knowledge partner with the Genitourinary Cancer Society of India, Andrology India, and also so many societies have come together today because everybody is celebrating, and this is a 3-day bonanza. There is a USI ISU program on 13th morning. All are invited to join that. And before that, these 2 days are the master class. Dr. C. Malkarjun is with us. So many uro-oncologists, like it is difficult to name, Dr. Kalyan Sarkar, Ginil, Tongonkar, and so many are there with this limited time of 5 minutes. It is difficult to thank everybody and welcome everybody, but I'll tell you that the scientific committee, which is studied with Hemant Tongonkar, Amlesh Seth, Sudhir Rawal, Ganesh Bakshi, Anant Krishnan, Shivaraman, D. Ramesh, Anup, Aditya Pradhan, Raman Tamar, and Anurag Singla. They have done wonderful work. Our event management is also leaving no stone unturned, and with this I'll request Dr. N.P. Gupta, our Gushi secretary, Dr. N.K. Mohanty, our Dr. P.N. Dogra, who is in Andrology India president, and also all the stalwarts like Dr. Kumar Prabhash is there, Dr. Puneet Aluwalia, and Dr. Umesh Sharma, who has started the proceedings, Dr. P.P. Singh, the Secretary of Delhi Urology Society, Vineet Talwar from Rajiv Gandhi Cancer Hospital, Rajesh Taneja from Apollo, and Hemant Goel from RML Hospital. and Sudhir Raval, of course, is there. And with all these stalwarts in uro-oncology and also interested in men's health or andrological health of all the population of India, the guidelines creation for India, the pioneer work in research and development in India, they are all together today, and we will be having wonderful sessions. And with this, I welcome everybody, and with the Dr. N.P. Gupta, Dr. G.K. Rath, Dr. N.K. Mohanty, and all other organization members.
आप या तो मेरे को बोल दो, मैं आगे का इसका वो करूँगा.
Declare that this master class gets inaugurated, and we start the master class with this. Thank you. Thank you. Dr. Sumit.
Dr. Sumit, unmute.
Hello.
So Dr. Sumit will be coordinating mainly, and me, Dr. Sumit, and Dr. Umesh is also there, and we will be coordinating this program. And Dr. Sumit, you are unmuted now. You
Yes, sir.
And invite the USI office bearers.
Yes, sir. Thank you, sir. I would like to invite our USI President, Dr. Anant Kumar, sir, and USI Secretary, Dr. Rajiv TP, sir, for their opening remarks and inauguration of the webinar. Dr. Anant Kumar, sir.
Dr. Anant has joined. I think Dr. C. Malkarjun is there. Dr. Okay. Malkarjun, our president-elect, Dr. Malkarjun, please.
Rajiv, I think it is most welcome that you asked me to talk, but I don't think that I'm just waiting to listen. In fact, that's the interest I'm having it today. It's a wide variety of topics which you have been covering for the next 2 days. The greatest part is divided into 2 days rather than extending it for 4 or 5 hours on a single day. That would have been a difficult thing to hear. But anyway, all the best to all the participants, and we are all hoping to have a great, fantastic session ahead. Thank you very much.
Thank you, sir. Thank you. Dr. Rajiv TP, sir, Secretary USI. I think Dr. Rajiv TP have not joined.
Impression that it is 6:30. They are starting. They will chip in one by one. I think we start.
Okay, sir. Okay, sir. We will be starting our first session. And we'll be discussing the diagnostic dilemmas. I
think Dr. Sumit, we get the blessings of Dr. N.P. Gupta and Dr. P. Venugopal for that.
Yes, sir. Sure.
Dr. N.P. Gupta was there?
Yes, I am very much here.
Yes, sir.
Hello. Let us listen to Dr. Venugopal first. He's senior. Dr. Venugopal, please start.
Thank you, NP.
I know your interest in CA prostate.
Thank you very much. I think this is a very fantastic, well-organized program as far as the agenda is concerned. I only hope that all of us keep the time allocated. And at the end of it, I would like to appreciate Rajiv Sood and the organizing committee. Inform us and tell us what exactly can be practiced in India. There are so many things that is coming in the literature, which is far beyond our expectation to practice at the moment in India. If at the end of this meeting, we can come to conclusion what can be practiced and what cannot be practiced, or what is not possible to practice for some time to come, I think that will help us all practicing urology a lot. Thank you.
Thank you.
Thank you, sir.
Thank you all, and good evening to you all. And as an introduction, I can only say that cancer of prostate in all aspects, starting from its screening, diagnosis, management, surgery, radiation, chemotherapy, immunotherapy, everything is controversial. And there is no clear-cut guidelines. Science is changing very fast. It's like a dynamic process. That's why these kind of updates are very important to know what is going on latest. But as Dr. Venugopal said, it is very important. We should not follow blindly the West, the USA and Europe. I think so. We are in India. We are working in India. So we have to see our Indian patients, and more important, that the money spent by the Indian patient from their own pocket. So that's why the treatment is very important, what they can afford. You may have a lot of things all around the world, but not necessarily we should follow them blindly. So with this introduction, I'm very much impressed with the program, and let us hear the speakers, what they want to say, and then we will discuss it out. Thank you very much for inviting me, and I will start the first session. And who are the other chairperson for the first session, please?
Yes, sir. Thank you, sir. The first session will be Diagnostic Dilemmas, and the chairpersons for the first sessions are you only, sir, Dr. N.P. Gupta. After that, Dr. R. Ranga Rao and Dr. Rajesh Taneja. Dr. R. Ranga Rao is a medical oncologist and chairman at Paras Hospital in Gurgaon. And Dr. Rajesh Taneja he's a robotic uro-oncologist and senior consultant at Indraprasth Apollo Hospital, New Delhi. So with I would like to invite Dr. N.P. Gupta, Dr. R. Ranga Rao, and Dr. Rajesh Taneja for being the chairpersons of the first session. And I would like to request the chairpersons to kindly ask the speakers to discuss their topics in the time limit so that we can stick to the time.
I'll add, Sumit, I'll add only one thing. Dr. Anant
Yes,
Kumar and Dr. Rajiv TP are waiting. Somehow they are not finding their audio video working for this conference. They will be soon joining. Continue.
Sure, sir. Sure.
Okay. So let us start the first session, because as you know, time is important. Start in time so we can finish in time also. So the first session is on diagnostic dilemma, and we have got 3 speakers in this session. So I will invite the first speaker, Dr. Ravi Mohan Mahmuduro from PGI Chandigarh, and he has a lot of interest in the field of uro-oncology. He is going to talk to us about the PSA, how to balance the benefit and survival and harm, actually, you know. So, Dr. Ravi, please start your.
Thank you, sir. Thank you.
Dr. Taneja to introduce the other speakers. Dr. Ravi Mohan.
Yes, sir. Sir, is my screen visible?
Yes, yes.
And I'm audible.
Yes,
yeah.
yes.
Yeah. Thank you very much, sir, for those kind words, kind introduction. And I sincerely thank Professor Raju Sood for such a tremendous effort for educating all of us. And I feel honored to be a part of this meeting where we have a galaxy of people with huge experience. And I'm an opening batsman. So, and this topic is the most contentious topic ever in the rest of the world as well as in our country. So let me try to strike a balance as we proceed through my talk. So we all know that prostate cancer screening, it is controversial. And why is that? Because it is one of the most common cancers to have, especially in the West, but not all cases die because of the cancer. Screening with PSAs greatly increases the number of cases being diagnosed with very little survival benefit, and treatment options have significant side effects and expense. In the subsequent slides, we'll see this. So it is said that more people die with prostate cancer than because of it. That means this study showed that at the age of 80 years, if you do an autopsy of patients who died, 60% of them would have an indolent cancer. They would not have died because of prostate cancer. So more people die because of it rather than, more people die with it rather than because of it. And this database shows that prostate cancer is the most commonly diagnosed cancer in the West. But if you see the death rate, it's only 9%. It's the second leading cause of death. Again, once the prostate cancer is diagnosed, the typical time from diagnosis to death for all the other cancers like breast, lung, and other cancers averages between 2 to 6 years. For prostate, it is 14 years. So we can very well see that a cancer which is detected early has a lead time of 14 years. So we have to be very careful in selecting whom to treat. This is also true across almost all the risk groups. And it typically shows that the deaths start to occur after 10 to 15 years of diagnosis. So which makes a point that it is most common, but it doesn't kill. And the lifetime risk of developing a prostate cancer is about 10.5%. However, the lifetime risk of dying because of prostate cancer is just 2.3%. So what happened in US? Because we don't have any Indian data, so we'll mostly discuss the Western data and then come back to India. What happened in US in 1986 when they introduced PSA screening was approved, they had a sudden peak. You can see imagine the peak which they had by 1992. There's so many cases of prostate cancer diagnosed, but then they realized that they are not dying and neither it is helping to the patient. So there was some rationalization. But despite that, when in 1990s, when the screening was decreased, despite lower screening incidence, the mortality continued to decline. That means even when the patients were not screened for cancer, they were not dying because of cancer. The mortality of prostate cancer diagnosed patients continued to decrease. This is a very important point to understand. So does that mean that we don't screen patients of prostate cancer? No. It is the second leading cancer killer in men, so we cannot just ignore it. But we need to discriminate who to be biopsied, which cancers need to be treated, and how to improve the diagnosis of prostate cancer, how to improve the diagnostic accuracy of a prostate cancer while screening. Now, let's see what the guidelines say. Almost all the guidelines, there's so many guidelines, all of them, the top four say don't do any prostate cancer screening at any age. AUA says that it should be shared decision making. ACP says that it should be discussed, we should discuss benefits and harms. And NCCN says that again, it should be shared decision making. And all of them put a specific age range in which it should be done. Not that it should be done at all age groups, but it has a specific age range. But in 2018, USPA, United States Preventive Service Task Force, changed its guideline from no screening to a grade C recommendation for men between 55 to 69 years to be allowed to screen. And again, with a big caveat that they should be discussed about the harms and benefits in detail and about the problem of false positives and so on and so forth, and not to screen patients beyond 70 years. So what does it mean? That between 55 to 70 years, we discuss it, not just do it. And beyond 70 years or old, we don't do it. And then a concept of opportunity screening versus organized screening. So all the guidelines which I just mentioned is a part of organized screening, that you define age group, you define the time duration, you define the cutoff values. That's an organized screening, and which would limit the number of cases where unnecessary being diagnosed. Whereas opportunistic screening is one which is done in India, like countries where you don't have your own database, we don't have our own cutoff values. So a patient walks to your clinic, you just do a PSA without even understanding what that PSA is going to do, both to the doctor and to the patient, because it is not specific. It is not only specific to prostate. There are so many other situations where, apart from cancer, where PSA increases. So from the major trials, we know that it does reduce the risk of prostate cancer mortality, but it is associated with a significant harm. It does reduce the risk of metastatic disease, but it causes significant sexual and urinary difficulties. This graph clearly shows that although you see that there is a 29% absolute reduction in prostate cancer death, but to prevent that death, over a span of 11 years, you have to screen 1,055 men. And in those 1,055, all of them to be followed for 11 years. And that is where you prevent one death. So that is a scale. And it doesn't come at this forest plot of the various trials does clearly show that patients who were offered radical prostatectomy versus conservative treatment, the conservative treatment scores with respect to urinary incontinence, with respect to risk of erectile dysfunction. It is also true even for radiation therapy. So it is very clear that treatment of early diagnosed prostate cancer has some harms. So for what we can summarize is one prostate cancer death averted per 1,000 men screened multiple times, followed for 10 to 15 years. And then radical prostatectomy associated with 20% to 30% increase in both incontinence and erectile dysfunction. Even radiation is associated with erectile dysfunction and bowel dysfunction. So there are a few more issues. What is a normal PSA? Is it same for all the races? Is it same for all the age groups? We don't know. And for India, we don't even have a clue. And then there are various causes of false elevation of PSA. So this audience doesn't need those causes to be mentioned. A normal PSA, as in the Western data where they have a community-based screening program. So a normal PSA is for 50 years, it is about 0.7, the median value. And a rise more than 0.75 per year is worrisome. Anything less than that, probably we don't bother. And it is also true that a men with PSA of less than 1 at 60 years probably never would die because of prostate cancer. So these things have to be kept in mind. There are certain age specified and race specified cutoff values, and this table clearly shows what are those cutoff values for different age groups and what is the risk involved, what is the chance of detecting a prostate cancer. In PCPT trial, one of the most discussed trial, the PSA less than 4 had a cancer probability of 15%, and PSA more than 10 had a cancer probability of 67%. So it is very clear that as PSA increases, the probability of having a cancer does increase. It is also seen that if the PSA is more than 10, the probability of cure because of cancer also decreases. So these two things are important. So we have to, now we are approaching a zone where we need to rationalize which patients to screen. So based on this NCCN guidelines, which says screening to be done between 45 to 75 years, they say that when the PSA is less than 1, one can repeat PSA between 2 to 4 years. When it is 1 to 3, repeat it 1 to 3 years, 1 to 2 years. And when PSA is more than 3 or a suspicious DRE, one can consider biopsy. But to further improvise our PSA, elevated PSA, one should add the various biomarkers, consider adding biomarkers like the free PSA, and there are various cutoffs. Free PSA, the prostate health index, the 4K score, and PCA score. These scores essentially add up to improve the specificity of an elevated PSA. And multiparametric MRI is another very significant adjunct where you can identify whether there is a lesion or not whenever you have an elevated PSA. And these are the various specificity, improvement of specificities. So whenever the free PSA is less than 10%, it is about 50 to 60% specific for patients to have a prostate cancer for a PSA which is between 4 to 10. This PHI includes PSA, free PSA, and pro PSA. Again, it has a specific cutoff values, and 35 is considered as a cutoff where the probability is more than 1/3. Similarly, 4K score uses the 4 prostate specific calcarein, and it has a cutoff value of more than 7.5 where it outperforms PSA alone in diagnosis. And MRI, we know that the Pirate 2 version, which is one of the most simplified versions to follow, where you know that 1 and 2, if you have 1 and 2 type of lesion, you don't actually have to do anything to them. So adding PSA with these modalities would probably help us to screen the patients better. Now, there are certain high-risk groups, race and family history. It is known from the Western data that African American have higher PSAs than whites, and they also have a higher chance of dying because of prostate cancer than the white people. So it is race has something to do. And it also seen that as the number of members of family increases, first degree relatives from family increases, the number of the chances of having a prostate cancer, both high risk and low risk, does increase. And one can go to the website, there are various risk calculators. So this helps in a shared decision between the patient and the doctor, where you can put all the data in the risk calculator and you can know what is the chance, and then accordingly, it creates a good confidence between the doctor and the patient. What is about Indian scenario? We don't have a clear-cut data. It's no brainer. And we also know that prostate cancer incidence is increasing. There's no doubt on that. But we have 2 significant studies which are published from our own setup, and both are controversial. One study says that the mean total PSA and age-specific PSA range tend to be lower for Indians than the Western population. And the other study says that the PSA cutoff should be increased to 5.4 to avoid unnecessary biopsy. So, there are 2 contrasting studies, both from our country. So we actually need to have our own database. And we all follow opportunistic screening, which I just mentioned. So we have to be careful again, the cause of the harms which we are doing. So dear friends, gentlemen, for balancing this harm versus benefit, my take home would be that we should screen at a right age, not all patients, that between 55 to 65 years. It should always be a shared decision between the patient and the doctor. And we should also screen high risk population, especially those with family history. And with the elevated PSA more than 4, we might add all these other parameters to further enhance our specificity of detecting a prostate cancer. And all said and done, we need for the study for defining our own cutoffs. And thanks to Professor N.P. Gupta sir and Dr. Raju Sood that we have already in the process of creating our own guidelines. Although in future we might have our own epidemiological data to follow those guidelines. Thank you very much.
Thank you, Dr. Ravi Mohan, for giving a very balanced view. However, there are some questions that we will take later on. Or the organizers, have you planned some questioning now only? Is anybody?
Sir, we can take up to 2 questions and other more questions can be discussed in the chat.
Okay. So I like to make one comment, Ravi, as you have mentioned in your talk, that if a man who is around 50 years and his PSA is less than 1, then we should do screening at the end of 2 or 4 years like that. We advise that at the age of 50, at least 1 PSA. We can't say that you don't need any PSA or something like that. And after that, the treating doctor can decide what should be the frequency of the PSA. Your comment.
Right, sir. Sir, so this is the Western data. I honestly don't know, and I think your wisdom would answer that. But I honestly don't know what would be our Indian scenario, considering that there are always, whenever we do radical prostatectomy, we'll say that we have a lot of prostatitis and things like that. So we really don't know what is our Indian scenario with respect to PSA cutoff. But Western data does clearly show that if a patient has a PSA less than 1 at 60 years of age, then the chances that he would ever develop a prostate cancer related death is virtually negligible, less than 10%. And that's why there is no need to do a PSA further. But if the PSA is less than 1 between 55 to 65 years, then we can do the screening between for every 2 years or 3 years and things like that.
Taking the clue from the Sanjay Gandhi paper, what you have mentioned, 5.7 nanogram.
5.4, yes.
So whenever we get a patient between 4 and 6, we discuss with the patient, we give him a choice. And if he is willing to wait, then I think so we wait at that time, don't jump. And we repeat the PSA after an interval of 3 or 6 months to see what happens. The moment it reaches to 6, we then say, all right, go ahead with further investigation.
Right. And I think that we should also, my personal opinion would be that we should also use all these various indices like the PHI and other indices to really improve our specificity of that elevated PSA when the PSA is in that 4 to 10 range.
Regarding these tests, the PHI is now recently available in India.
Yes, sir.
Which is around 2,000 rupees. But 4K test is costing around 2 lakh rupees, you know. So you are just giving 2 lakh rupees and they will also give you probable diagnosis. So in our clinical practice now we are relying more on multi-parametric MRI.
Yes, that's what I was trying to say.
That should be the message, go very clearly.
Yes.
That instead of spending money on these costly tests, better we can do a multi-parametric MRI. Of course, you will need a good radiologist to read and interpret this MRI.
Right, sir. Perfectly said.
Anyone else like to ask any question on this topic only? If no, then I request Raju, Taneja, Rajesh, please, you can introduce the next speaker.
Thank you, sir. Thank you very much.
Thank you. Rajesh, unmute karo. Rajesh, you can unmute yourself. Someone to help Rajesh Taneja?
Click on the screen and then play the presentation.
Rajesh, Taneja, can you hear? Your voice is not coming. No. Sorry, your sound is not coming. Rajesh, please unmute yourself.
Hello.
Now we can hear you.
Yes, this is audible, sir. Please go ahead.
I cannot hear.
Dr. Rajesh Taneja, sir, you're not audible. So meanwhile, Dr. Rajesh Taneja is connecting. Can we continue, sir, with Dr.
Okay.
Hello?
I will introduce the next speaker, Dr.
Yes, sir.
Amitabh Singh. He is the consultant, Department of Genito Uro-Oncology at Rajiv Gandhi Cancer Institute. And he has got a very keen interest in uro-oncology, and he's a bright future for all of us. Dr. Amitabh is going to speak on active surveillance for the localized, the low risk and intermediate risk prostate cancer. Dr. Amitabh, please.
Thank you, sir. Good evening. Thanks for nice words. Good evening, respected teachers, my dear seniors and friends. So today I'll be talking on active surveillance for low and intermediate prostate cancers. What was its past, what is its present, and what will be the future of active surveillance. As Dr. Ravi sir has already elaborated very nicely that most of the prostate cancer patient harbors low risk disease and they live for a year with the prostate cancer and they don't die with the prostate cancer with a very good quality of life. Although PSA screening has led to the over treatment, over diagnosis, and ultimately the radical treatments for the CA prostate led to the decrease in quality of life because of the side effects of the radical treatment like erectile dysfunction, urinary incontinence. So what we know from the recently concluded 3 randomized controlled trials, first one is the PIVOT trial, where they compared the radical prostatectomy with the observation for the localized prostate cancer patient. And they found there was no significant difference in overall or prostate cancer specific mortality. Although they analyzed subgroup for the intermediate risk patients, which consisted of 34% of the overall cohort, and they found that RP was associated with the improved overall survival. In another trial, SPCG4, they compared watchful waiting with the active treatment like radical prostatectomy for localized prostate cancer, and they followed the patient for 18 years of the period. And they found watchful waiting group had a higher overall mortality and cancer specific mortality in comparison to the radical prostatectomy arm. But in fact, we compared watchful waiting with the active treatment. In watchful waiting, we exactly wait for the patient to become symptomatic. And when they become symptomatic, we intervene. So we don't know whether active surveillance has equal outcome with the active treatment or not. To answer this question, the investigator again did PROTECT-T study. And they found that there is no significant difference in overall survival between and prostate cancer specific survival between surgery, radiotherapy, and active monitoring. And it's not surprising with these data and the good quality data of active surveillance, the confidence has increased in clinician and patient regarding the active surveillance. And the use of active surveillance has gone up significantly over the last 4 or 5 decades. Although the most experience of the active surveillance has come from the single institutional prospective studies and the pioneer institution were the Sunbrook institution from the Canada and John Hopkins from the USA. So John Hopkins had a very stringent inclusion criteria. They followed Epstein criteria for the inclusion of the patient for the active surveillance, where Sunbrook Institute, where Closed et al. Conducted this study. They included low risk as well as favorable intermediate risk group also, where the Gleason 4 has less than 10% of the volume in the disease. A special mention requires for the Prias study, whereas almost all the studies are single institutional prospective studies, whereas the Prias is a consortium studies, where they have included more than 18 institutions, more than 150 institutions from the more than 18 countries, and they have included more than 5,000 patients. They have their own inclusion criteria. Mostly they have included low risk disease following Epstein criteria. So if you'll go by the experience, the monitoring protocol, so mainly we discuss John Hopkins and Sunnybrook inclusion criteria and their monitoring criteria. John Hopkins monitoring criteria were very stringent, where they did PSA monitoring every 6 monthly, they did DRE every 6 monthly, they repeated confirmatory biopsy at every 1 year, whereas Sunnybrook did PSA every 3 for 2 years, then every 6 monthly after that. They repeated first biopsy at 3 years. After that, they repeated every 2 to 3 years another biopsy. And if you come to the outcome, it is not surprisingly to see that although the surgical intervention rate was higher in the John Hopkins patient cohort, it was 37% at 5-year duration, and it was 50% at 10-year duration in comparison to the Sunnybrook. But the percentage of metastasis and prostate cancer specific mortality was lower in John Hopkins criteria, John Hopkins cohort patient in comparison to the Sunnybrook, because John Hopkins had a very stringent criteria for the selection of the patient for active surveillance. So depending on this very good quality data, active surveillance has been included in various guidelines. Although most guidelines recommend active surveillance as a preferred treatment for the low risk patient, whereas some guidelines also include active surveillance as a treatment option for the intermediate risk patient with a careful selected patient. So there are several reasons for the selection of or the recommendation of active surveillance in intermediate risk group. In one large multi-institutional autopsy study, it was found that more than 50% of Asian men were found to have a Gleason grade of more than 2 at the time of death. And this intermediate risk group is a very heterogeneous disease in terms of both clinically and genetically. And if you see that tissue grade progression is very uncommon, it has been estimated at a rate of 1 to 2% per year. And with the ISUP 2014 consensus, the group grade reporting has been mandatory, and it has been also mandatory that if there is any Gleason 4 grade, then you must report the percentage of Gleason 4 grade, because Gleason 4 is the real prostate cancer, because Gleason 3 has not been considered as a cancer at all. It doesn't express various neoplastic characteristics like expression of proliferation, embryonic, neuronal, hematopoietic stem cell gene, EGF, EGFR, AKT pathway, HER2/neu, angiogenesis pathway, or TMP, RSS, ERG fusion. So in one multi-stable study, it has been found that the disease progression was the main reason behind the dropout from the active surveillance program. So there are several factors which might help in choosing better intermediate risk patient, like age. It has been considered that younger patients have a lower grade of the disease. Percentage of Gleason 4 disease is very important issue. If any patient who is having more than 10 to 20% of Gleason 4 is not recommended for the active surveillance group. PSA level has not been found significantly correlated with the group grade reclassification, although PSA density has a very good correlation with the group grade classification. Afro-American and Canadian patients have been found to harbor very high risk disease in comparison to the other ethnicities. Genetic risk factors have been studies that it has been found that MMR or genetic this DNA repair gene defect like BRCA2, BRCA1 and this ATM, those patients, they have a very high risk of harboring a high grade disease. They have high risk of recurrence. They have high risk of metastasis also. Cell cycle progression score, genomic prostate score, and genomic classifier have also been studies to help the clinician to determine which patient is good for the active surveillance in intermediate patient risk group. And for the radiological investigation, MPRI definitely has been proved a very good investigation to characterize which patient to be included for the active surveillance or not. It has been proved a very good investigation for the selection of active surveillance patient, for the monitoring, and when to intervene also. It determined the appropriateness of the patient candidate because of its high negative predictive value for high risk disease. It has a very strong inverse correlation between ADC and Gleason group grade. And if there is a study which shows that if you perform MP-MRI prior to entering active surveillance, it can exactly reduce 29% number of inappropriate active surveillance candidates from the program. So the question is whether this MP-MRI can replace the biopsy in monitoring. Definitely not, because there are still some concern with the false negative rate of the 16% of the MP-MRI. But still MP-MRI can be included in the decision-making algorithm, clinical nomogram, along with the various genomic markers like PSA density, PSA doubling time, PCA3, to decide when to biopsy and tailoring your monitoring. There is one randomized trial called as MRIAS trial, where it has been found that if you do baseline multiparametric MRI fusion saturation biopsy, you can literally reduce your frequency of surveillance prostate biopsy without compromising your results. So MRI has also been included in various guidelines for active surveillance, especially in NICE and EAU. It has been it should be done at the time of enrollment, and it should always be done before confirmatory biopsy. But the question is whether biomarkers should be used for the active surveillance or whether MRI should be used for the active surveillance for follow-up. So there are various pros and cons for the biomarkers. There are various good and bad things for the MRI also. Regarding the future of active surveillance, I think inclusion of the various genomic markers, genetic profiling like mismatch repair gene defect in ATM and BRCA2, prostate genomic scoring, including various SNPs like single nucleotide polymorphism. And one study has showed a very good sensitivity for diagnostic metastatic disease up to 94% and negative predictive value of the 97% for the aggressive cancer. Newer imaging tools like high frequency 29 megahertz micro ultrasound has shown a very promising result in various studies. It has shown a significantly better outcome in terms of sensitivity and negative predictive value in comparison to the multiparametric MRI. We can use combination of biomarkers and imaging. We can use PSMA PET scan. The future is for germline analysis, interpretation of liquid biomarker with imaging, image-guided genetic cancer profiling for the better selection of AS candidates. So these are various genomic biomarkers, like 4 or 5 have been approved by the US FDA for the active surveillance inclusion criteria. So they like Oncotype DX, Polaris, Decipher, ProMark, Select MDS. And these have been included in the NCCN guideline also. So it has been included in the low risk and intermediate risk category. But in a very low risk category and high risk category, they have not been indicated. So coming to the conclusion for active surveillance is a preferred treatment for very low risk patient and in highly selected intermediate risk patient. So success of active surveillance depends on better selection, monitoring of patient, and choosing better trigger for the intervention. Newer imaging, genomic biomarkers, nomogram with combination of parameter will be instrumental in success of active surveillance. And inclusion of non-invasive method with better accuracy for diagnosis of non-aggressive disease will increase compliance for the active surveillance. So with this, I would like to thanks. And I'm now open for the question.
Yeah, thank you, Amitabh. Rajesh Taneja, can we hear you now? Yes.
Can you hear me now, sir?
Yes, we can hear you. You can ask questions. Yeah.
Okay. So no, I was struggling because my microphone was hacked by Zoom. They said you cannot speak. Anyway, so this is a very good talk, Dr. Amitabh, about the active surveillance, and you've covered almost everything. So my question to you is that what is the percentage? I may have missed because I had to go out again. What is the percentage of your patients in total cases of CA prostate that you see who are localized CA that you put on active surveillance in your practice?
Sir, we don't find too many patients who are fit for the active surveillance. If you'll ask me specifically for the data, so I don't think so. It would be more than 2 to 3%, though I'm not very sure because we have not analyzed.
Why do you think, can you enlighten us? Why do you think in India, a center like Rajiv Gandhi, we cannot find many patients for active surveillance?
So what the patient characteristic, what we are seeing in our OPD, they fall either in intermediate or high risk group. We don't any patient, we hardly see any patient with like PSA less than 10 and organ confined disease or diagnosed only by the less than 5% of the TORP chips.
So suppose I were to ask you that we need to increase our active surveillance at Rajiv Gandhi Cancer Institute. what would you recommend to the general urologist or general practitioners to do something that you get more patients for active surveillance?
So that is
what can be done. Yeah, this is important.
Yeah, this is important. Actually, we almost all of us are doing opportunistic screening, PSA screening. So we can't deny with this. And that's why I think there is a debate whether we should like prescribe PSA screening or not. But definitely with opportunistic screening, when we increase our opportunistic screening or institutional based screening, definitely we will have more and more patients for the active surveillance, because we have to have a very low or low risk or favorable intermediate risk group. If we want to increase our active surveillance program, then we have to include our favorable intermediate risk group. Like that means 3+4, where 4 Gleason grade should be less than 10% or 20%. Although in Western countries, most of the institutions, they follow it that it should be less than 5% or less than 10%. So I think opportunistic screening is the only answer for this thing, because our patient, they don't come early.
Thank you very much, Dr.
Dr. N.P. Gupta sir wants to.
I like to make one comment, Amitabh, because in your PROTECT trial, and they have found out that patients on active surveillance who have metastatic disease, they all have Gleason 4.
Yes, sir.
So you know, it is very important we should have very good pathologists actually, you know.
Definitely.
Never highlight this particular thing, but I will highlight that if we don't have a very good pathologist, they should give you accurate histopathology along with the markers. Also, they should do the study. Then only they can confirm the patient have only 3+3, not 3+4. And you are saying that we should increase our pool by adding 4. I don't agree on that personally, actually, because what I have seen, if anybody who has 4, they definitely need a definitive treatment. Whatever way you want to do, that's a different. Thank you. We can go to Dr. Rangarao is here now.
Yeah, I'm here, sir.
Can I request you to introduce the third speaker?
Right.
Akhil Kapoor,
so I think we have a very interesting topic in the next one. That is the genomic testing in the localized tumors. Which one to do, when, and how does it help in the treatment decision making? And then we have Dr. Akhil Kapoor, who's an assistant professor on medical oncology from Tata Memorial Hospital in Mumbai. I'm sure he'll address all these issues, and then we will have the question and answer sessions. Over to Dr. Akhil, please.
Thank you, sir. So Dr. Amitabh has already set the ball rolling and have highlighted some steps where the role of genomics are in the prostate tumors. I will build on it. I have deleted few of the slides which were similar to him to save on time. So I don't have any conflicts of interest, and I have taken most of the presentation from this ESCO guideline, which was published this year, with the Egener et al. Being the first author. So I will be targeting few of the these 4 questions one by one, and this will help us to understand the role of the genomics in prostate cancer. So I will start with the first question directly. Are there molecular prostate cancer biomarkers with which we can identify patients who are most likely to benefit from active surveillance? Yes, there are. So Decipher biopsy and the Decipher post-operative, these are the biomarker test which has been approved by FDA, and this is done on FFP, the frozen tissue, block tissue. Others are Oncotype DX, Prolaris, and ProMark. Each one has a different indication, and we will deal with one by one, step by step. So in prostate cancer, most of us will be aware that TMPRS ERG gene fusion is the most common gene, which is present in around 50% of the prostate cancer, but it has consistently not shown to be associated with the clinical outcomes. While the germline DNA mutations like Bracha, BRCA2, MSH are present in subset of patients, around 6% of patients with localized prostate cancer and 12% with metastatic prostate cancer, and these have shown clear association with the prognosis and outcomes. So this slide shows the summary of association with prostate cancer risk. BRCA1 and BRCA2, these are A grade. That means we have very strong association and shown clear association. MMR has shown moderate association. Others are also there. For ATM and CHIT2, these are somewhat associated, but not so strong associated as BRCA. So just one slide about the role of Bracha and Prognosis in the localized prostate cancer specifically. So in the diagram, you can see this gray line is for BRCA2 and this one is for non-carriers. You can clearly see for BRCA2 positive patients, the prognosis is poorer. So for localized cancers also, if BRCA2 mutation is present, it signifies poorer prognosis. So whether using BRCA2, if we know that patient is BRCA2 mutated, where we more strict surveillance will be helpful, we don't know this yet, but it is definitely there that we should be aware that BRCA2 patients have definitely poorer survival. So some gray areas remain in the management of localized prostate cancer, especially in this NCCN low or favorable intermediate risk prostate cancer. For example, when a patient of high volume grade 1 group is there, but patient has high volume. Similarly, when patient is of Gleason 3+4 is 7 and percentage of positivity biopsy score is around 50%, and there are no more than one NCCN intermediate risk factor, their area is a gray area. Whether you will select this patient for active surveillance or treatment, it is somewhat dicey. So each of the commercial biomarkers which I showed in the table seems to be independently improve the prognostic accuracy of the clinical models for identifying men with biologically significant disease. However, we should be aware that there is no data which has compared these tests individually, and we don't have the data of long-term impact of including or excluding these patients for surveillance versus treatment. So I will be moving to the next question. Are there molecular biomarkers with which to diagnose clinically significant prostate cancer? So I will discuss a scenario. For example, a man diagnosed with unfavorable intermediate risk prostate cancer, whether we will add ADT to radiation therapy or not, that is a question. Radiation oncologist will refer it to the medical oncologist, asking whether it is beneficial to give add ADT to radiation or not. And here, so there are multiple studies which have shown that various tissue bed tests like Ki67, EZH2 overexpression, they help in diagnosing significant disease, but there is insufficient evidence still to support their clinical use. Also, results from these are often dependent on technical aspect. This is very important. These tests are costly. These tests have very technical terms, and it is important to have a proper lab which is analyzing it and communicating the same to the clinician to decide for the further treatment. So understanding reproducibility and concordance and other performance metrics are very much important for these emerging biomarkers. Another question, are there molecular markers to guide the decision of post-prostatectomy adjuvant versus salvage radiation? This is a very important question. For example, when the PS is undetectable after radical prostatectomy, the value of adjuvant radiation is an area of debate and clinical controversy. More than 60% of such patients will remain metastatic free at 10 years without post-operative radiotherapy, and thus the adverse effect of radiotherapy can be avoided with proper selection. Then how to select? So there is a study by SWOG H794 which showed if you add adjuvant RT in PT3 disease, you will save 1 life after treating 9 patients. However, to the contrary, there are 2 big studies, URTC and ARROW study, which failed to demonstrate any survival benefit of this adjuvant RT. So this Decipher Genomic Classifier and the PORTOS biomarker, which are commercially available, it is for a high Decipher score will help to inform patient in counseling. So, and we can tell the patient that adjuvant RT might be beneficial. And also if you are adjuvant RT, what is the benefit of combining androgen deprivation and radiation to this patient? So it might help us in making clinical decision making, but it does not definitely gives the final answer, and it needs to be individualized. In the absence of prospective clinical trial, as I said, the routine use of these biomarker is not recommended, but it can help in certain situations. Decipher test, just one line in detail about it. It is uses the expression of 22 selected RNA markers from over 1.4 million RNA markers of the prostate cancer, and it helps to discriminate to the tune of 80%, which outperforms all the clinical variables which have to the tune of 50% discrimination. Coming to the question, what are the comparative strengths and weakness of genomics versus MRI in identifying clinically significant prostate cancer? A slide was shown by Dr. Amitabh, and I will be highlighting few important points that there is increasing use of both MRI and genomics to identify clinically significant prostate cancer, and prognostic value is the most focused data. So in general, with the use of MRI guided biopsy, the detection of higher grade prostate cancer has improved because of targeted biopsies. And still, the most important point that we should understand, around 10 to 15% of clinically significant cancers are not visible by the MRI and they might be missed. So genomic tests have demonstrated the ability to predict the adverse pathology findings at the prostatectomy, risk of recurrence, metastasis or death in these patients. Also, in men with very low risk disease, primary question may be whether there is a missed index lesion, and MRI may provide most information in such cases. So we need to balance whether you are selecting MRI, whether you are selecting genomics, whether you are selecting both. This is important. So in contrast, for men who are favorable intermediate risk, the primary question is underlying biologic aggressiveness, and this can be more stratified by genomic classifier. However, another point, genomic information is can be limited due to multifocality of the tumor. For example, if you have sampled less biologically aggressive tumor, you might get wrong answer. So here, MRI will help in guiding the biopsy, and on the biopsy, you can discuss about the genomic testing in these patients. So summarizing the points till now. So there are currently commercially available biopsy-based multi-gene expression markers, most importantly, Decipher, Oncotype DX, Prolix. Apart from this, one protein-based biomarker and ProMark, and each seem to be independently improve the prognostic accuracy of clinical multivariate models. The clinical benefit of these is selected patient has not been prospectively demonstrated. This is important. This is an evolving field. We have not yet come to the point that we can surely say that these are going to be helpful. NCCN might recommend it, but we are not going to copycat NCCN, and we need to have our own guidelines because our patients are different and we have different financial scenario. If radical prostatectomy exhibits adverse pathological features and PS is undetectable, Decipher genomic classifier might help us to stratify and identify which patients are more likely to benefit from the post-operative RT versus early salvage RT. And also, as I told, if radiation is planned, whether to include concomitant ADT or not. Also, for the final word, the data suggests that MRI genomics can each provide important information, and this might help in decision making. So the key is choosing wisely, choose according to the situation, choose according to the available finances, choose according to your particular practice. Don't copy the Western data, and we need to have our own data. We don't have our own data in this scenario at all. So this is till now, this is a theoretical concept for us, and we are learning it, and hopefully if it comes in the practice, some patients might be affordable for the same. Thank you.
Yeah. Thank you very much, Dr. Akhil. I think you made it very, very clear. This is just a theoretical concept and not an implementable or a practical aspect. But even in the research setting in Tata Memorial Hospital, do you have any data on this aspect of the molecular subtyping?
No, sir. This, apart from the Bracha testing, Bracha 1, Bracha 2, ATM check 2, we are not having these genomic classifier. These are the FDA approved multi-gene testing. We don't have these. These are a commercial tests which are available only in a specific situation, but these are not available to us till now. So we have the genomic test, but not the commercial test.
And the Bracha 1, Bracha 2, you're doing in the metastatic settings or even in the early prostate cancer?
Sir, we are till now doing in the locally advanced. That is, if it is nodal positive, then we have started doing it, but not in the early prostate cancer till now.
So if there are any questions from the audience or the other panelists or chairpersons on this topic? I don't see any questions from the audience on this aspect. I think then we close with the permission of the chair, sir. And I think thank you very much, Dr. Akhil. I think it's been a wonderful session, very, very educative. And I'm sure in the future we will have some tests to look forward to in this setting. Thank you.
Thank you, sir.
Thank you, sir. I would like to extend my heartfelt thanks to all the chairpersons and all the speakers for conducting a very nice sessions. And for further continuing the session, I would like to invite chairpersons Dr. Ranjan Dey. He's a consultant urologist at ILS Hospital, Kolkata. And Dr. Arun Chawla. He is a professor and head Department of Urology, KMC Manipal Hospital. And he's also co-chairman of Indian School of Urology, USI. And Dr. J.G. Malani, sir. Dr. J.G. Lal Malani, sir, is a consultant urologist at Hinduja Healthcare Surgical Hospital at Mumbai. And Dr. Dilip Dhanpal, sir. He is a urologist and urological surgeon at BTM Layout, Bangalore. So I would like to invite our chairpersons, new set of chairpersons, and we'll be continuing with the speakers. I would like to invite our chairpersons to invite our speakers, and I would like to request them again. We are already 10 to 15 minutes late in our presentation. So
Dr. J.G. Lalmalani will conduct this session primarily. Please ask him to come up.
Dr. J.G. Lalmalani, sir.
Good evening, everyone. Can you hear me?
Yes, sir. We can hear you.
Yeah. So I welcome my co-chairpersons, Dr. Ranjan Dey, Dr. Dhanpal, and I hope that Dr. Chawla will join us in a couple of minutes. It gives me great pleasure to be part of this symposium to remember Prostate Month, which is going on now. And my first speaker will be a very, very prominent uro-onco surgeon, Dr. Ginil Kumar, a very dear friend, and also a member of the USI Council. And he is going to cover prostate cancer biomarkers. I think Dr. Akhil has already helped us understand some bit of it, but I think Dr. Ginil Kumar will do a great job and make it more easy for urologists to understand and learn what is the implications of prostate cancer biomarkers. So without much ado, I would request Dr. Ginil Kumar, Professor Ginil Kumar, who is a consultant at Amrita Institute of Medical Sciences, Kochi, a very dear friend, a wonderful speaker, and I give the mic to him. Dr. Ginil Kumar, Professor Ginil Kumar. Yes, can I have Professor Ginil Kumar, please? Hello. Is Dr. Ginil Kumar there? I thought I saw him. Ginil?
Yeah, can you hear me?
Yes, sir, we can hear you.
Yes, very well.
Yeah, can you see my slides?
Yes, sir.
The primary slide is visible.
Yeah, we can see.
So Ravi has rightly told us the confusions precipitated by prostate-specific antigen regarding the overdiagnosis and overtreatment. Dr. Kapoor has elaborated a lot of factors about biomarkers. I'm just polishing a few points on the biomarkers to discuss about the clinical implications about these biomarkers in our day-to-day practice. 20 years back or 30 years back, when PSA was the only marker, we never thought of having one more marker because we thought that is the best marker we have. But we know that the PSA is not, PSA has made a lot of confusions in the management of prostate cancer. And regarding the prostate, we know that prostate is a single organ, but has got different genetic makeup regarding the malignancy, because it has got a lot of array of genetic alteration that is happening in the early phase in the primary prostate cancer. Further on, when it changes to a castrate-resistant prostate cancer, a lot of changes are happening again, and it is entirely different from the neuroendocrine prostate cancer. So unless we have an individualized regime or protocol for managing these tumors, we won't be doing justice. And that is why the prostatic biomarkers has got a lot of role in each and every phase of the management. But unfortunately, it is, as rightly told by the previous speaker, it hasn't gone to a level where we can routinely use because of various factors, including the cost and a compromised specificity and sensitivity. Yet, what are the points on which we can use these biomarkers regarding treatment decisions? Before that, coming to the biomarkers, we can broadly divide the biomarkers into 3 categories. One is seen in the urine. Most important 2 biomarkers are PCA3 and Temper's ERG. These are actually MRA. Common factors about these 2 markers are we have to express with prostate, squeezing the prostate or giving a massage and get the urine for sampling. The blood, we have got time-tested PSA, but to make the diagnosis more accurate, we have got other markers like prostate health index and 4K score. CTC, survivin, chlorine, etc. are new markers, or this CTC is circulating tumor cells in the blood, which can give us good idea about the prognostication of the tumor, how the tumor is going to behave, especially in advanced cases. Tissue markers, most important one are Decipher, Promax, and Oncotype D, and Polaris. And these tissue markers actually help us to categorize the patient, which treatment we have to give after retrieving the tissue by radical prostatectomy or biopsy, whether we can go for active surveillance or radical treatment. So coming back to the different markers, PCA3 was one of the most discussed one. That was one of the earliest one. It was detected in the urine. It is actually an MRI, and it is more specific for the prostate. It is amplified many times in the malignancy, and you can see that the area under the curve of detection of tumor is more than 0.7 and is fairly good marker and is FDA approved. Temperus to ERG gene rearrangement also is detected in the urine. It is again an MRA, and a scoring system is there with Temperus and the PSA MRA, which is called Temperus ERG score, and it has proved that it can improve the sensitivity of all the risk calculators. So in the blood, PSA or PSA derivatives are the main metabolite which is detected, and which has come into prominence is the pro-PSA, especially in the prostate health index. The pro-PSA along with the free PSA and total PSA is assessed to have the prostate health index. So it has shown that it can increase the detection rate of prostate cancer and also gives a hint about the aggressiveness of the tumor. 4K score is almost similar like PHI. It again detects along with the PSA isomers human kallikrein 2, which is a glycoprotein, and it increases the sensitivity and can avoid unnecessary biopsies, especially in the PSA range of 4 to 10. And also it can give a clue about the chance of metastasis or aggressive tumors in the later phase of the management. And also can select the patient for active surveillance. So among the tissue markers, as Dr. Akhil Kapoor has rightly told, these are the main Polaris, Decipher test, Oncotype DX, and Promar. Initial 3 are genetic tests, and last one is a protein test. So tissue markers helps us to prognosticate the tumor and select the patient for active surveillance even in less than 10, even all the criteria is there for active surveillance. With this tissue marker, we can segregate the patient who may go for progression. So putting everything together in the clinical application, there are markers which is useful in the screening to avoid overdiagnosis, markers useful in the diagnosis in the biopsy stage, like to prognosticate, to select the patient for a second biopsy in a negative biopsy. There are markers useful after radical treatment, after biopsy or a radical prostatectomy, to plan them, to know the chance of failure. And there are markers in the progression phase, especially in the metastasis and CRPC, to guide the selection of treatment. I mean, for individualizing the treatment. So different tests available in the biopsy phase are PSA, PHI, and 4K score, and in the urine, PCA3. And to select patient for repeat biopsy, again, all these markers along with the compressed gene score. In the post biopsy setting, it is mainly the tissue markers like Oncotype DX, Promark, Prolaris, and Decipher. So putting it together in an algorithm, once you diagnose a high PSA, we can select patient who who must undergo the biopsy, because these patients has got high chance of aggressive tumor. This can be, we can get a clue with biomarkers like 4K score, PHI, select MDX, and PCA3. And when the biopsy is negative, to select the patient for a rebiopsy, again, a PCA3 and MDX can be used. After biopsy, again, to select patient for active surveillance, we can use the tissue-based tumor biomarkers. And after treatment, to prognosticate and select for probably adjuvant treatment, or to select a patient who may progress, Prolaris and Decipher may be useful. When the patient goes to a metastatic phase, a circulating tumor cells or ARV7 can either prognosticate or give us a clue about which treatment we are to give. Like in ARV7, there is a change. We can select whether a hormone will be effective or not. So in NCCN has actually recognized these tumor markers in the management of prostate malignancy. Decipher, Prolaris, Oncotype DS, and Promark are discussed in the post-radical treatment in prognosticating and for long term, and also to select patient for active surveillance to avoid a radical treatment. So you can see that the biomarkers are especially useful in low, intermediate, and high risk, and may not be much useful because already the pathology will tell us the prognosis in very low risk and very high risk. So again, in CRPC, we have different biomarkers which are useful for individualizing the treatment. As Oncocyte DX or ARV7 will predict response to abiraterone and enzalutamide. A genetic alteration like mismatch repair or a microsatellite instability will tell us whether it will respond to pembrolizumab. Now the olaparib is recognized by or approved by FDA in BRCA1 and other genetic alterations. Also, rucaparib has come in genetic alterations of BRCA gene. So, so these factors are recognized in the guideline also. So finally, to conclude, biomarkers helps us in reducing the overdiagnosis and overtreatment in the initial phase of the management. It helps us to prognosticate the organ-confined tumor and to select appropriate patient for active surveillance, and helps in individualizing the treatment in advanced tumors. Thank you very much.
Thank you, Dr. Ginil Kumar. Professor, I am only concerned, tell me which of these clinical markers are available today in India and which are you using? Because even in Bombay, I think many of us have no access to many of these biomarkers which you have described. what so far has been your clinical practice where you have been able to utilize this?
Experience is almost full except for the BSA, BRCA genes and all the genetic alterations in the advanced phase. I'm not using any screening tests because of two factors. One is the availability of the test, and second is the cost factor. And because of the confusion about the clinical utility, because majority of the patients are not, as already discussed, candidates for active surveillance. Mainly, these markers are for selecting the patient for active surveillance in the initial management. And a second area where it is useful is to plan for rebiopsy when the PSA is elevated. We have PHI or Prostate Health Index score available in India. PCA3, temperature, all these markers are not available. Then in the Decipher and Decipher is available.
Polaris.
Polaris is also available. These two are available in Indian setup. Then in the advanced setup, we have got next gene sequencing for different genetic alterations, especially in advanced tumor, to select and individualize the treatment. This is available and it is useful when the patient is failing after initial hormone or chemotherapy.
Okay, thank you, Professor Ginil Kumar. Can I request Dr. Dhanpal to, Dilip, if you can ask any questions or you can introduce the next speaker, please.
Can I share a few, one or two slides only to help us as far as these markers are concerned? Good.
Why not? Surely.
Next slide. Go to the next slide. There are a number of basically available markers which we do routinely, and I thought I should list it out. Simple marker like metastatic status, it will tell us not only the prognostic but also the predictive value. Performance status, that will also tell us the prognostication as well as predictive. The time to CRPC, these are also predictive. So there are so many routine tests we carry out which help us in determining the prognostic and the predictive value of all these markers. I thought I will add it. And of course, there are recent ones like AR splice variants, circulating tumor cells, AR mutation, somatic DNA. These are the later versions. But we do a lot of tests and we have these tests immediately available to us. It can give us some idea what is the prognostic value as well as the predictive value. This is just, I thought I should share a few of these points. Thank you.
Dilip, can you introduce the next speaker, please? Or Ranjan would like to do that?
Ranjan, can you do that? Because I don't have on the screen.
Okay, no problem. I'll introduce. So, excellent talk, Ginil, for emphasizing the role of biomarkers in screening, biopsy, rebiopsy, stratification, and prognostication. So, we'll move ahead. The next speaker is Dr. N. Raghavan, and he'll be talking on transperineal MRI targeted biopsy. Is it a better option for detecting clinically significant prostate cancer? Over to you, Raghavan.
Sir, hopefully all of you can hear me now.
Yeah.
Thank you.
Very clearly.
Okay. Thank you, Dr. Arun, and good evening to all. I am Dr. N. Raghavan. I work in Apollo Hospitals, Chennai as a consultant uro-oncologist. So the topic given is, it's a very tricky topic. It says transperineal MRI targeted biopsy. Is it a better option for detecting clinically significant cancer? So there are lots of subsection to it, transperineal MRI targeted biopsy. So to put it in context, to my best knowledge, such MRI fusion biopsy is available only, at least I know it is available in Rajiv Gandhi. I'm not sure whether it's available in any other center in India. So the transperineal versus transrectal biopsy discussion has truly started in the last few years. The people who are doing transperineal biopsy saying It's no more a transfecal biopsy, as they say about the perineal biopsy. The choice of modality for any biopsy should look at the question about outcomes, toxicity, availability, learning curve, cost, and then finally patient's perspective as well. The bulk of the literature for transperineal biopsy is from literature. To be very honest, almost the majority of the world are using transrectal biopsy even today. And the transperineal biopsy available in the literature are primarily template biopsy using a grid. The transperineal biopsy using the stabilizer is something which has come recently in the world in the last few years. I'm yet to see a bulky literature on that. So whatever I'm going to do, I'm going to reference it to the transperineal template biopsy. Even the PROMISE trial, the famous PROMISE trial, which looked at the biopsy and the MRI, was using TPM as the transperineal template biopsy as the reference point. Now, the general perception of about the transperineal biopsy is that it's a higher complication rate. There is a need for a general anesthetic. It's an inpatient setting, cost, and can we do it on a routine basis? That's a question that is asked. So let us look at the progression of transperineal biopsy. In 1999, one of the first studies to be published came. It was a prospective 254 patient study. Then 2010, the 467 patients retrospective study came. And 2015, we have got better with it. We have 145 patients coming in. So transperineal biopsy has been there for a while, but slowly making inroads into the system. So let's start a question saying, is transperineal biopsy any better than transrectal biopsy? 12 core, 12 core. So the detection rate for transperineal and transrectal are absolutely similar, 42 versus 48%. There is no difference between the two groups as well. And that is a study published in 2008. Now, is the transperineal biopsy more accurate than transrectal biopsy in the final Gleason score and the clinical risk category? Now, if you look at the, this is the BJU article, 2015 article, and it compares the TRUST biopsy and the TTB biopsy, 33 versus 30.4%. There is no difference in the final Gleason sum. But in general, people agreed that transperineal template biopsy should be considered as a part of the system before active surveillance to make sure that all the cancers which otherwise might be missed is picked up as well. If you look at the location and the pathological characteristics of the cancer in a radical prostatectomy compared to a transperineal and a transrectal biopsy, you will find that transperineal biopsy compared to transrectal picked up more anterior tumors and picked up smaller size tumor and picked up higher rate of extracapsular extension. So transperineal biopsy do have a slight advantage. Now, if you look at whether transperineal biopsy picks up better the laterality of the tumor, especially with relation to focal therapy like HIFU, the rates of pickup are very similar. And once again, I'm telling about all transperineal biopsy as the template biopsy that is given. Now, the next question. So we understood that transperineal and transrectal picks up very similar amounts. Transperineal picks up more amount of anterior tumors, slightly higher amount of extracapsular extension. So that's what we have understood so far. Now, let us look at whether there is a significant affecting to the transperineal biopsy compared to the transrectal biopsy. So we find that transperineal template biopsy has an higher accuracy of predicting the Gleason score overall compared to the transrectal biopsy. Now the question of MRI fusion biopsy comes. Now imagine the goodness of transperineal and the MRI fusion. It's an amazing thing, but is it widely available? To my knowledge, it's available in one center, if not another 1 or 2 centers. It is definitely published in the literature. It's not widely available. The problem, as always said, is that because we are accessing the prostate through a different angle through the transrectal route, we always tend to miss the anterior zone, and there is a higher incidence of septic complication, including hospitalization for the same. And with the progressive increase in the antimicrobial resistance, that becomes a cause of concern as well. if you look at the immediate complication between the transperineal and the transrectal route, the TP versus TR, the discomfort rate with transperineal route is actually higher. But the rest of the minor complications are very similar. Urinary tract infections are much higher than rectal biopsy than transperineal biopsy. So Declan Murphy wrote an article, we should move, all of us should move to transperineal biopsy in view of the superbugs that are available. The infection rate with the transperineal biopsy is 0 compared to the trus biopsies. But trus biopsy has the convenience of outpatient setup, or the transperineal biopsy needs an OR, the logistics, and the available technology. If you look at the cost and the comparative effectiveness, the trus is, let us say 1, a sedation trus is nearly 2 times, general anesthesia is 2.5 times more, sedation fusion biopsy is 2.5 times and beyond, sedation with MRI biopsy is higher as well. And even for the transperineal biopsy using the stabilizer, you need to go through some degree of training and the availability of the kit for that as well. Training is essential. At this point of time, transperineal biopsy is done by a few people in India, and definitely people in London are doing it to my best knowledge. The place where I got trained, they do a lot of template biopsy using the grid in an anesthetic setting. So the initial experience of performing in-office ultrasound guided transperineal biopsy was published in 2016. It is that is using what we call the stabilizer for doing the transperineal biopsy as an outpatient setting. The transperineal template biopsy is well tolerated because you are under anesthetic in the most of the time, but the urinary retention part is much higher compared to the trus biopsy. So let us look at the whole summary in a single slide. The cancer detection rate with transperineal is much better. The complication rate with transperineal is much better compared to the trus. The availability of transperineal is limited. The learning curve is there with the transperineal because it's not widely available. Transperineal template needs a proper setting including this, and if you are going to combine that with an MRI, you are going to have a much more cost increase. From a patient perspective, transperineal is nicer. So that's where we are, but we are not going to abandon trus. Transperineal biopsy is not necessarily the answer, but it is part of the answer for the picture. It is definitely, if you're going to combine this with MRI, it is going to increase in the reduction. It is even possible that the number of biopsy courses you need to take can be reduced with the transperineal MRI fusion, but we have a serious limitation in the availability, training, and the cost. Thank you so much for the opportunity.
Thank you, Raghavan, for a very crisp presentation. A quick question, Raghavan. If you have a patient who can't be put in lithotomy, do you think transperineal biopsy in any other position will be a limitation? Number 2, if you have a patient who has a large prostate and there is very less space between the prostate and the undersurface of pubic bone, do you think it's a limitation for this transperineal biopsy?
Sir, both of the things that you said are 100% limitation of transperineal biopsy because you need a proper, if not a slightly extended lithotomy for that. And you need, if you want to take transperineal biopsy in a proper way, then you need a template for that as well. And the problem with large prostate, let us say 80, 90 gram prostate, is to access under the pubic bone into the anterior zone. The very selling point of the transperineal biopsy that you can take an anterior zone biopsy gets defeated when it goes under the pubic arch. In India, the number of patients with knee replacement is higher compared to hip replacement. In the West, we used to have a lot of patients with hip replacement who comes for transperineal biopsy. So we used to put, a discordant lithotomy for them. The one with the hip replacement will have a normal lithotomy. One with the hip not replaced will have an extended lithotomy. So both of them are very true. Now, if you are going to take them and an MRI fusion with it, then you need the machine for that and the availability of the resources as well. The biggest selling point for MRI fusion biopsy is that you just don't need to take number of courses. You just take a 3-4 course especially from the places where you are, very highly suspicious of. Now, whilst it is very good, we don't have a proper literature to say that we can completely abandon trust. All of us get an MRI fusion biopsy and take only 3 course or 4 course. We still are not in that place yet.
Thank you, Raghavan. Over to you, Dr. Danpal. Over to you.
It's one method. It's a fusion biopsy, what is called as cognitive fusion biopsy. That is, the transrectal ultrasound images are placed in front of the person doing the biopsy, especially if he's a good radiologist or a good clinician. And his MRI picture is also there. Patient is in lithotomy position. And he does the biopsies. You don't need a template. You can get a reasonably good samples with this kind of, but it has to be with a good experience. Using a transrectal ultrasound in the operator's brain as well as the MRI images in the operator's brain and does the biopsy. You can get good results also. So it's not necessary that you need to have a template.
Sir, one another point I wanted to add, at least today, the transperineal biopsy needs a side-firing probe, which is, BK or Hitachi or any of the side-firing probe. The vast majority of the biopsies, at least in India, are done using a transvaginal probe, a biplanar or a single planar transvaginal probe. The number of people who have an access to transrectal probe, which is a biplanar probe and a side-firing probe, is limited. That is one of the essential requirements for a transperineal biopsy.
Thank you, Raghavan. Any question from other faculty?
The other thought, I'm Dr. Lalmani again. The other thing is the indication for transperineal would be when we have a patient who has undergone AP resection or who has a tight stricture of the rectum, anal canal, and this is where probably transperineal will be of importance.
Sir, for transperineal biopsy, you need to have a probe inside the rectum to visualize the prostate. So for patients who have undergone AP resection and the rectum is closed, there is no choice other than to do a CT guided biopsy or an MR guided biopsy, or to do a TRP and get a biopsy from there, sir.
There's a question from Dr. Gupta. Raghavan? Yes, sir. Please go ahead, sir.
Dr. Raghavan.
Yes, sir.
The current indications for the transperineal biopsy are the anterior located tumor. If you have done a multiparametric MRI and tumor is on anterior, you should do a perineal biopsy, then the transperineal. The second thing is a patient who have got any bleeding disorder, they should be offered perineal biopsy, not the transrectal biopsy. Third thing is the infection or any pathology in the rectum like piles and all that. Otherwise, they will have more complications. So one can select out the patient who are really indicated for the transperineal biopsy. Otherwise, for a routine case, I think so we are doing very frequently this fusion biopsy and all that, and we have not come across many problems.
Sure,
sir. Can I make a small comment, Dr. Arun, sir? Ravi here. As I understand, transperineal probably offers a better diagnostic outcome than transrectal. That is very well evident. Only that we are not very well tuned or trained to do a transperineal biopsy, and it comes at a cost of 0 infection rate. So eventually, 10 years from now, when you have bugs all which are resistant, going through the rectum would be a problem. So I think the message is clear. That transperineal has a potential value. As of now, since we are not trained much, so we use it only selective situations. Am I right, Dr. Raghavan?
Thanks, Ravi. You are perfectly right. So transperineal biopsy in the next 5 years may become the standard of care. Yes. But for that, I can see only 2 things happening. One, we need extensive training. All of us train each other. Secondly, I think it will be wiser to invest into a transrectal probe with a side-firing probe, so that the biopsy is much more accurate. Using end-firing vaginal probe, very good with a trans for the biopsy. We need that investment to be made in centers. Regards MRI fusion transperineal biopsy, I'm not sure. Sudhir sir has just joined in. I think it might happen in future, but I'm not able to see it in the next 5 years.
Raghavan, I was there already. I was listening to your talk.
Good evening, sir.
Actually, I agree with you that transperineal is way to go in future because there is no infection rate and you can hit the anterior tumor. And we actually already had planned for this. but somehow because of the pandemic, we could not do that, and we could not send our faculty for training.
Sure.
I think PGI Chandigarh is doing it. This has many advantages over transrectal, and with fusion biopsy, when you can put a probe in the rectum and hit from the perineum, that actually will give you the best mapping of the prostate, which you can utilize in the treatment also when the in future hopefully focal therapy is coming, either by cryo is already there in India, and by HIFO.
Sure, sir. Thank you so much, sir.
Dr. Rahul, thank you very much. I'd like to thank Dr. Rajiv Sood and my colleague chairpersons, Dr. Ranjan De and Dr. Dhanpal. And I'd like to thank my speakers, Professor Ginil Kumar and Professor Raghavan. And I would like to hand over the mic back to our organizers. Thank you very much.
Thank you.
Thank you,
Jackie. Dr. Rajiv, thanks a lot.
Thank you, sir. Thank you. So now we'll be concluding our first session and moving on from our first session, Diagnostic Dilemma, to the Localized and Locally Advanced CA Prostate. I would like to invite Dr. Anurag Singla to further conduct the session and moderate it.
Hello, everyone. Good evening. Am I audible?
Yes, yes, sir.
Okay, thank you. So now we are moving from session 1 to session 2. The topic of session 2 is localized and locally advanced CA prostate. And I would like to invite the chairpersons. We are already 20 minutes late on our schedule. So I would request that we have the 4 lectures, 10 minutes each. So questions can be taken after 40 minutes after all completion of the 4 lectures. So I would like to invite Dr. Prabjot Singh. He's an additional professor of urology at AIIMS, New Delhi. Dr. Shailesh Raina, he's consultant uro-oncologist in Hinduja Healthcare Surgical, Mumbai. Dr. Kaustov Talpatra, he's a national head radiation oncology in Kokilaben Dhirubhai Ambani Hospital, Mumbai. And Dr. P.N. Dogra, he's ex-president USI, ex-HOD AIIMS, New Delhi. Dr. B.C. Roy, national awardee, and currently working as a senior consultant in urology in Sir Gangaram Hospital, New Delhi.
So,
yeah, Dr. Prabhu.
So, Dr. Shailesh, are you going to start?
Hi.
Sir?
Aap shuru kijiye, I'll take the next speaker.
So, thank you, Dr. Rajiv Sood, for making me chairperson for all the stalwarts of uro-oncology. So, I am very privileged. So without wasting time, I'm going to start. I may request Dr. Puneet Ahluwalia for his first talk. He's a senior consultant uro-oncology and robotic surgery in Max Institute of Cancer Care at New Delhi. He's going to speak about expanding indication of radical prostatectomy. Are we stretching the limits? Dr. Puneet, over to you.
Thank you, Dr. Prabjot. I hope I'm audible enough.
Yeah, you are audible.
Yeah. So thank you so much for this opportunity. And good evening, everyone. I'm going to speak on the topic of expanding indications of radical prostatectomy. Are we stretching the limits? So we all know that radical prostatectomy has a defined role in localized prostate cancer, and especially in very low risk, and intermediate prostate cancers. So there is no controversy in that in these indications, it's very well a part of treatment options. And I'm not going to touch upon these ones. So since the topic is expanding indications, I will restrict myself to the other areas. So the other one are the high risk or very high risk prostate cancer. And I'm going to touch upon the scenarios where radical prostatectomy is classically not indicated. So let us see what is the evidence in the literature for this for these scenarios. And in this presentation, I don't have any conflict of interest, and I don't, by no means I'm advocating a radical prostatectomy for the scenarios for which it is classically not indicated. It's just to freshen up and just to know what is the evidence in the literature. So to present my talk, I will divide it into the 3 major scenarios. One is high risk, very high risk prostate cancer. Other one is lymph node positive disease. And the third one would be the oligometastatic prostate cancer. So these 3 are the ferocious ones. So for the high risk and locally advanced disease, what the guideline says is to offer RP only to selected patients which are young and well preserved with no fixity to the pelvic wall as a part of multimodality treatment. So this study, which was published in 2014, so this compared the radical prostatectomy or radiotherapy in high-risk prostate cancer. And this was a systematic meta-analysis, and they concluded that overall and cancer-specific mortality rates appear to be better with RP in high-risk prostate cancers compared with RT. So this was a retrospective meta-analysis comprising of multiple studies. And if you see in this meta-analysis, the prostate cancer specific mortality, most of the studies favored radical prostatectomy for prostate cancer specific mortality, whereas one study favored radiotherapy. And when we talk of overall survival, even that study was not that favorable, but somewhat favorable for radiotherapy. So this has been a topic of debate in many conferences we have attended in high risk prostate cancer. But moving on, when we compare the effectiveness of radical prostatectomy, this study was done to compare the effectiveness of radical prostatectomy with adjuvant radiotherapy versus radiotherapy plus ADT for men with advanced prostate cancer. So this was again a retrospective database study from SEER data, and they included all the men with locally advanced or regionally advanced prostate cancer, which was T3, T4 cancers, and even N1 prostate cancers. So more than 13,000 patients were included, and they concluded that in both locally advanced and regionally advanced prostate cancer, patients who initially were treated with RP plus radiation therapy had a lower risk of prostate cancer death and improved overall survival as compared to those treated with RT plus ADT. So from radiation versus prostatectomy to like working brother in arms. So this is the breakup of the subset of patients in this particular study, what I'm talking about. You can see in multiple, rather all the subsets, when we talk about prostate cancer specific survival, whether it was T3A, T3B, or N1 or T4, if you include RP as a component in your treatment modality, so the prostate cancer survival was much better than if you do it with radiation plus ADT. So this follow-up was done for 10 years. And then again for overall survival, the results were no different. So for T3A, T3B, N1, and even N4, T4, the overall survival was better if RP was included in the treatment modality. So, and this paper was published a long way back in 2008, which evaluated multimodality treatment and compared surgery followed by RT versus RT followed by surgery. And we can see the complications and the incontinence, erectile dysfunction, proctitis were different. They were better with surgery before rather than radiation therapy before. The dose given for the radiation therapy was higher if radiation was given before, and there were higher complications for surgery in irradiated field. So what the potential advantages of upfront surgery are: the accurate staging by surgery, decrease or avoid ADT exposure, best local control, and avoidance of long-term radiation toxicity. So if we talk about our own data of last 5 years, so we have around 600 patients now, and out of which around 82 patients had T3B alone. And if we take patients who don't have any adjuvant treatment given over the follow-up of 20 months, mean follow-up of 20 months in 75 patients, more than half of the patients had no biochemical recurrence. This is for T3B and 0 patients. So, and again, if you talk about functional outcomes in our data, so continence outcomes were almost similar, whether it was high risk or non-high risk. However, potency rates were lower for high risk, and that's understandably so, because if you do a surgery for high risk, you tend to go do a wider resection. Talking about quality of life, there was no significant difference in both the groups. So now coming to the second scenario, lymph node positive disease. So this study evaluated the long-term outcomes of patients with lymph node metastasis treated with radical prostatectomy without any androgen deprivation therapy. So this is a study from Memorial Sloan Kettering, and this included 369 men which were included between 88 to 2010. And then they concluded that a considerable subset of men with lymph node metastasis remained free of disease 10 years after RP. So you can see from the Kaplan-Meier curve that at 10-year cancer-specific probability, survival probability was 72%, and at 5 years it was almost 90%. So if you talk about biochemical recurrence-free survival, mind you, this is a patient with lymph node positive disease and without any androgen therapy. At 5 years, the biochemical survival was, recurrence-free survival was 35%, which was again at 10 years was 28%. So most of the biochemical recurrences occurred within first 5 years. And if the patient is biochemical recurrence-free at 5 years, there was 81% chance that he will be free of recurrence at even 10 years. And again, comparing the number of lymph nodes, if it was only a 1 lymph node or 2 lymph node, the patient did much better as compared to more than 2 lymph nodes. So again, regarding our data from patients who had lymph node positive disease post-operatively, so 50 patients over mean follow-up of 25 months without any antibiotic treatment, over 20 months, 34% had no biochemical recurrence. So for these group of patients with either seminal vesicle disease or single lymph node disease, there are distinct advantages of radical prostatectomy. There could be a long-term recurrence-free survival in significant proportion. But however, you need to counsel the patient that there's this most likely is going to require any additional therapy, and multimodality therapy for management for the most is the norm. Now coming to the metastatic, now we're talking about oligometastatic here. So the definition of metastatic disease itself is a very controversial one. There have been various definitions, and the Chartered trial also defined those. So in all, the high and low disease volume could be defined as high volume as presence of visceral mets or more than 4 bony mets, or presence of at least 1 met beyond the vertebral bodies and pelvis. And anything other than this would be a low metastatic disease. So right now the treatment recommendation is ADT plus docetaxel or ADT plus abiraterone for these patients. So there has been a controlled phase 3 trial, randomized controlled phase 3 trial, for which tells that in low volume metastatic burden, radiotherapy to the primary tumor can help in improving the overall survival. This has even come in the EAU guidelines now. So, however, the evidence is weak, and they say that we can offer castration combined with prostate radiotherapy to the patients who first presented as M1 disease and have low volume disease. However, contrary to that, if the patient has high volume disease, the evidence is strong that you should not offer any local treatment outside the clinical trials. So what the literature says, this is a study done in 2014, and they included more than 8,000 patients with the primary metastatic setting. And out of 8,100 patients, almost 7,800 patients did not receive any radiation or any surgery. And 245 patients received radical prostatectomy and 129 brachytherapy. So the numbers are very contrasting. So mostly patients didn't receive anything. So what they found out was that for survival probability, it was better for the patient who received radical prostatectomy or brachytherapy as compared to the patient who did not have any of the treatment for local disease. So they further divided that which patients were benefited most depending upon the various risk factors in this metastatic population scenario. And they found out that whether it was less than one or one risk factor, and whether it was 2 risk factors or even more than 3 risk factors. If you give a localized therapy to these patients, the survival probability was still higher than the patients who did not receive any surgery or radiation. This is a recent one, article published in Current Opinion in 2020, and they summarize that patient with low volume or low risk metastatic cancer, good response to neoadjuvant androgen deprivation therapy and good ECOG score appear to be best candidates for surgery in metastatic oligometastatic disease. So they said that this decreases morbidity of local recurrence, eliminate need for secondary procedures. Also, the continence recovery and complication rates are not very different from non-metastatic patients. So who are the ideal patients according to them were those who had good performance status, low PSAs, less than 20s in the risk factors in the previous study, absence of extensive disease, absence of visceral metastasis, and also a good response to neoadjuvant androgen deprivation therapy with a nadir PSA of less than 1. So where we stand now today, as of day, is that the evidence for localized treatment in metastatic setting for radiation, we have a big evidence. However, there is no conclusive evidence for surgery. Surgery may decrease morbidity, but results from prospective trials are awaited, and then only we can say something about it. So this is the ongoing prospective, one of the trials which is being done by MD Anderson. The recruitment has already been completed, and they last updated in May 2019, but I could not find out any results, early results of this trial. So we need to wait for the prospective trials, and then we will be in a better position to decide upon that. So thank you very much.
Thank you, Dr. Puneet, for excellent and elaborative lecture. I have just one comment that when I was doing my residency in 2007, and robotic system was introduced in India, and that time we were just operating 3+3 Gleason score, and for intermediate as well as high risk, we were just offering hormone therapy as well as radiotherapy. But with time, now we are reached up to the stage that we are doing radical prostatectomy on oligometastatic disease. What do you think? What is the cause of such migration of thoughts? Is it a better understanding of the disease or some kind of pressure over us?
I don't think any pressure should guide our practice. I think in Indian scenario, we rarely get in our data also of 600 patients. Most of the patients are intermediate risk at least. So very low risk or 3+3 disease is very less. And I think the overall idea is to give a better treatment to the patient and seeing the oncological results. And as we progress, the follow-up of these patients increases, and we get better knowledge about the outcomes of these diseases. So I think it changes. I think the overall treatment, whether it is for the oligometastatic or whether it is for the localized disease, will depend upon what the follow-up says. So right now, the literature for oligometastatic, I would not say that I've already presented that it is very, very naive. So yes, but for intermediate risk and high risk, I think we can definitely do it. And we don't have randomized trials for locally advanced disease as well. But I think the people in this audience, senior people, Dr. Rawal or Dr. Gupta, can better comment upon their experience about the follow-up of the patients, how they are doing, especially for the high risk or very high risk or locally advanced disease.
Okay, thank you, Dr. Puneet. Sir, over to Dr. Shailesh. Shailesh sir, you are not audible. Sir, please switch on your mic.
Unmute. Am I audible now?
Yeah, sir. Yes.
Can you hear me now? Well,
Yes,
I
sir,
thank
yes, sir.
thank Rajiv and thank USI and thank the Indian School of Urology for inviting me to chair this session. I've thoroughly enjoyed these webinars, and I sort of stayed till late hearing all of it. My question to you, sir, is that you have any experience of neoadjuvant ADT in high-risk localized cancer prostate? Neoadjuvant ADT and then go on for radical prostatectomy. Would that be a helpful strategy?
So sorry to disturb, but we are already very late.
Okay.
And there is a panel discussion on treatment of high-risk non-metastatic prostate cancer. I think we can cover.
Okay. Sorry. All right. Then may I please request my friend Dr. Raghunath to speak on robotic perennial prostatectomy, something which is quite popular in Turkey at the moment. Dr. Raghunath, please.
Hello.
Yes, Dr. Raghunath. Welcome.
Thank you, sir.
You're audible. Please continue. Dr. Raghunath
Yeah.
is a senior uro-oncologist at Bangalore and very well known. It's a pleasure to introduce him. Please continue, Raghunath.
Thank you, sir. Very good evening to all of you. At the outset, I would like to thank USI and ISU for having me. My topic is robotic perineal radical prostatectomy, a resurgence of a robust surgical treatment. That's my topic. So these are my disclosures. I've done around 350 to 400 open radical prostatectomies by retropubic means, and I've done 407 robotic transperitoneal radical prostatectomies using SI system. I've done only one perineal robotic radical prostatectomy using the same system. I have not done PLND in that case. So my experience is very, very, very limited. I have not done open perineal radical prostatectomy. I don't have any conflict of interest. There are no RCTs comparing perineal versus other radical prostatectomy approaches. So I'm not here to debate which is the best approach. Also, the reason being, robotic perineal approach is just 4 to 5 years young. To understand this topic, we should go through evolution of radical prostatectomy. Young introduced the first perineal radical prostatectomy way back in 1905, and Millen, almost 35 years later, described retropubic radical prostatectomy in 1940. It took another 40 years for Patrick Walsh to describe anatomic retropubic radical prostatectomy. The Schuster later on, in 1997, he described the first laparoscopic radical prostatectomy, radical prostatectomy in USA in October 2000 in Detroit. And the Jihad Koch described first single port robotic radical prostatectomy. Asimako Paulos described the regius sparing radical prostatectomy in 2013. 3 years later, the first robotic assisted perineal radical prostatectomy was described by Jihad Koch, which is just 5 years old, after 111 years of describing the first perineal radical prostatectomy. You can understand from this how it has evolved, how much time it has taken to evolve from one procedure to another procedure, another approach. So with this, we have come a long way and still we are evolving. We don't know at this point which is the best approach. So from 1905 till 1970, almost for 65 years, open perineal radical prostatectomy was the predominant surgical approach for localized prostate cancer. Even now, the retropubic radical prostatectomy is just 40 years old, whereas this one was ruled for almost 65 years. Way back in 1957, Belt et al. Published the first series of around 229 cases of perineal radical prostatectomy in Journal of Urology. Despite of all these things, why perineal radical prostatectomy was not popular, though it provides the most direct access to the prostate, it is technically and ergonomically challenging procedure due to its deep and narrow confines of the perineal anatomy. Because of this, it did not become popular. And the Patrick Walsh anatomical description of radical prostatectomy was not available before 1980s to popularize this. With the refinement of retropubic radical prostatectomy and the application of nerve-sparing methods in 1980 by Patrick Walsh, he popularized retropubic radical prostatectomy though many patients were exsanguinated from DVC bleeding. So retropubic radical prostatectomy became popular with the development of laparoscopic as well as robotic assisted retropubic procedures. This is the reason why perineal radical prostatectomy was abandoned. Why do we prefer retropubic radical prostatectomy? Why not perineal radical prostatectomy? The preference for retropubic technique is based more on surgeons' habits. We have been daily, day in and day out, we are doing and we are seeing this, so it has become our habit. The retropubic radical prostatectomy, be it open or robotic, is less anatomically complex. The familiarity and training experience is definitely better even to the residents. All these are not based on evidence-based medicine, and till date, there are no RCTs comparing various approaches. So at this point of time, we don't know which is the best approach. So what are the challenges of perineal radical prostatectomy and how to overcome? There are two standard challenges, that is anatomical challenges and confined narrow space. So anatomical challenges with the robotic surgery has enhanced our understanding after Patrick Walsh and Ash Tiwari's anatomy. So we can overcome that. We know what is the anatomy better. And confines of the narrow span perineal prostatectomy, assistant cannot see what is happening inside. Only surgeon can see and surgeon can perform. But we can overcome this by perfect 3D vision and dexterity of the robotic platforms which are available now. Even single port is available now. The robotic platform definitely has enhanced our ability to perform dissection, reconstruction in a confined anatomical space to overcome these challenges. So if you ask this question, why we should not be trying this, there is no real answer for this. So to give you a brief perspective about how perineal prostatectomy done by robotic approach, there is a very small incision in the perineum, maybe 3.5 to 4 centimeter. We use only 2 instruments, unlike standard 3 instruments we use by robotic retropubic approach or robotic transperineal approach. And the scar is almost concealed. Of course, this is not a cosmetic surgery, but scar is concealed. And we don't enter the peritoneum. Since the perineal incision will be there, the complications are also very less. And we will be using a gel port, which is again an additional consumable. You can make out from the middle photograph that we use only 3 instruments. That's camera and 2 instruments, assistant port. What are the potential advantages of perineal radical prostatectomy? We should understand when we compare with the robotic transperineal versus robotic perineal prostatectomy. So it eliminates 5 initial steps which we do in robotic transperitoneal approach. That is, steep tendon proposition is not required. The bladder mobilization is not required. Endopelvic fascia opening is generally not required. However, newer techniques like Hood technique, where they don't cut that, they don't incise that. Definitely, dorsal vein complex control is not required. However, it is not required even in the radial sparing approach. This procedure, robotically, can be done using epidural anesthesia. So it can be done as a daycare procedure. So which theoretically translates to reduce the operative time, further reduce blood loss, though with robotic surgery, blood loss is less. With perineal robotic surgery, it can be further reduced. It virtually eliminates the risk of injury to the small bowel or major vessels intra-abdominally while putting the trocars, and definitely people have done this as a daycare procedure. What are the other advantages of perineal radical prostatectomy? Apart from this, it also avoids having to deal with extensive adhesions in patients with previous abdominal surgery, multiple abdominal surgeries, multiple scars, a lot of adhesions will be there. Injuries are more common, so probably we can avoid abdominal approach. Although robotic perineal radical prostatectomy uses carbon dioxide insufflation, it eliminates the need for pneumoperitoneum and its possible complications, particularly in obese patients. So obese patient, pneumo itself can give a lot of problems, and Trendelenburg position itself can cause a lot of problems. So we can avoid all these things. So robotic perineal prostatectomy can be performed without Trendelenburg position. It can be done perfectly in supine position. However, exaggerated lithotomy may be required. And Jihad Pauk, he has published first initial 4 cases where he discharged all the patients within 12 hours of surgery with minimal pain control compared to robotic standard approach. What literature says about perineal prostatectomy? There are a couple of articles. I picked up this first one published in 2017 from Turkish Journal of Urology from Olkan Group. And the same author has now performed around close to 80 surgeries In the initial series, he published only 15 patients between November 2016 and February 2017. Within 4 months of time, he has published 15 cases. However, the case selection was very stringent. They have used Da Vinci XI robotic platform. They avoided doing surgery in locally advanced prostate cancers. They're not chosen. So
Dr.
this is
Raghunath,
the
can you please?
yeah, I'll
finish?
summarize. Yeah,
Thank you.
these are the pre-operative demographic data. Maximum age was 71, maximum BMI was 33, and Johnson comorbidity was 3. And all 12 out of 15 patients had previous surgery. Prostate volume was around 65, and the PSA was maximum 12.1, and Gleason was 4.4+4. So these are the results. I would not go into the details of this. So the blood loss was very less, and the mean total operative time was less than 3 hours. Console time was around less than 1.5 hours, and perineal dissection time was around 1 hour. Early continence, these are very striking. Of course, with 15, it's difficult to comment. Early continence rates was 40% on day 0, and at 3 months, it was 94%. They concluded that robotic perineal radical prostatectomy is feasible and efficient method. These are the pros and cons of perineal prostatectomy. We use only through 2 instruments. Possible in epidural anesthesia, daycare procedure should be possible. Less pain, less blood loss because DVC is not divided. Steep Trendelenburg position is not required. This is very useful in cerebral aneurysm patients and patients with CVA. Less or best cosmetic scar, and which translates to less wound complications. PLND is definitely possible. And early continence, we don't know. What are the cons of robotic perineal prostatectomy? Gel point or gel port is required, which is an additional consumable. More than 80 grams prostate is very difficult to do. EPLND could be possible because even open perineal prostatectomy, some people are doing the extended pelvic lymph node dissection. Some reports of compromised rectal incontinence, but it is not reported very well in the literature. So why we should not be doing robotic perineal prostatectomy? If you ask this question, we clearly do not have an answer. RCTs are required between various approaches. If we understand its theoretical advantages and start applying in our clinical practice, I'm very sure and I'm certain that robotic perineal radical prostatectomy would result as a robust surgical treatment option. Thank you.
Thank you, sir, for excellent and difficult operation. You elaborated very easily, but I think this is going to be very challenging surgery in the future. It's difficult open, it must be difficult robotically. And of course, lymph node dissection is very tricky in this,
this procedure. Not difficult. It is not difficult robotically. Though with one case, it is difficult to conclude, but it is not difficult robotically.
Okay, sir.
I did for the first time. Without difficulty, I could complete it.
Okay, sir. Thank you, sir.
Thank you.
May I request Dr. Kostov to introduce next speaker?
Yeah. So our next speaker is Dr. Sudhir Ral, and I think he needs no introduction. He is going to talk on evolution of RARP technique, his preferences, and why. Dr. Raval is the president-elect of NZUSI. He is the director of surgical oncology at Rajiv Gandhi Cancer Institute. Over to you, Dr. Raval.
Thank you, Kostov. Can you hear me?
Yes, yes, you are audible, sir. Yeah.
Okay, that's great. So my topic is evolution of RARP technique and preferences, what I do at the moment. So I'll just go through my presentation. As the history is already has been told by Raghu, is that in 2000, Manivan did his first RARP, though before him it was Binder from Germany who did robotic prostatectomy, but he did half and then he converted the operation to open. That was the classic replication of open technique, except that it was antegrade, not retrograde, as it is done in open. But the first prostatectomy, robotic prostatectomy, or even the lab prostatectomy, they were done as the antegrade only. And since then, there are many evolution has occurred in technique, and there have been the different evolution in approach also. There is one evolution is that people have tried, and many centers they do extraperitoneal RARP. This avoid any interference with the bowel, and then you can do as you are doing with the open extraperitoneal radical prostatectomy, but it's not very popular. The other thing which has come in big is Roca stitch. This will be the open prostatectomy also, but then with robotic it got refined, and a lot of people suggested that it helps in the return of continence, but to my mind it does not. I'll show you the data also. There is another evolution in robotic radical prostatectomy, anterior approach, where you cut onto the prostate rather than away from the prostate, and you take a lot of anterior tissue and make an apron like tissue, which actually saves the dorsal sphincter and the vessels also, and this actually helps in return of the continence. This is being done by a lot of surgeons, and including me also. We also do this technique. In the beginning of our career of robotic prostatectomy, we were going away from the prostate, which was very easy to do as compared to the open surgery, and that is why our results were inferior. But then after doing this technique, we feel the results are better. Dorsal complex, vessel complex is not venous, it's a vessel complex. Ligation early or late, it can be done in any way. A lot of people have suggested if you do ligate late, then probably the margin positivity rate is less. Seminal vesicle first technique, dissection is from Anterior Approach. This was popularized by Richard Gaston, and this approach actually very good for the small prostate and when you have PSA less than 10. And then the people are doing this technique without cutting elbow endopelvic fascia from Anterior Approach also, and anyway from Posterior Approach you do not cut the endopelvic fascia at all. Then came the RS, ridges sparing RALP, that is Bouchardy, which is actually the thing which I prefer to do. Then after that came the robotic assisted perennial radical prostatectomy, which Raghunath has already told you. My understanding about perennial radical prostatectomy is when you go from perineum, you have to cut the perineal body, and then you have to cut the rectourethralis muscle. If you don't cut these two structures, you cannot reach to the correct plane, that is behind the prostate and the anterior to the rectum, where the Denon where fascia is there. You can see the perirectal fat. So when you cut the rectourethralis, that probably is involved in the return of continence. And the thing which similarly, when you do the ridges sparing radical prostatectomy, you do the same thing except that you do not cut the rectourethralis muscle. Otherwise, the dissection in perineal radical prostatectomy, either open or the robotic, it is same. But in ridges sparing, you do not cut the rectourethralis muscle in addition. Where in perineal you cut, and that is why probably the results, because I have done the open perineal radical prostatectomy, I have not found them better than the retropubic radical prostatectomy. So doing through the perineum robotics may not help at all. After this, the three things have come in literature. Not in literature, probably they are evolving, but definitely MPP is there in the literature. This is Mani Menon's precision prostatectomy, where he maps the dominant lesion. It is done for the patients who have one-sided lesion, where you remove the one part of the prostate on one side completely, either saving the neurovascular bundle or you remove the neurovascular bundle, and other side you leave the prostatic tissue. This is like doing partial prostatectomy, or you can easily achieve precision prostatectomy by the ablation therapy, either by the HIFO or by the cryo. But then Mani Menon group is popularizing this, and he has shown that the results of return of continence or potency are far, far, far better than when you remove whole of the prostate. In the line of this thing, Dr. Hemal is propagating total prostatectomy, where he does not remove the seminal vesicles at all. He leaves the seminal vesicle at all, and then he goes on to the prostate, and he claims that his results are better than the regular radical prostatectomy when you are removing the seminal vesicle and the vas. Then the third thing coming is the transvesical prostatectomy, which we saw video recently, and there was a webinar from Rishikesh by Ankur, and that actually is almost similar to the total prostatectomy, but he is removing the seminal vesicle from the bladder. Actually, it is more similar to the ridges sparing radical prostatectomy, and I don't think that it actually what happens is when you go from the inside of the bladder, you'll end up with a big bladder neck hole. While you come from outside the from out to in, you can dissect the bladder neck of the prostate, and that is why you'll end up with a small bladder neck hole. So in this technique, I have doubt, but in the future, maybe Ashutosh will tell us about this, what is happening. So if the ridges sparing prostatectomy, I am not going in detail because I have already talked this in many time in the platform, but I'll show you the few slides why I prefer. This plane, you can see that this is the approach to the ridges sparing prostatectomy, and this is the anterior approach, and this was described by the Swedish professor. These are the initial experience of the ridges sparing in 3 patients by Bouchardy, and he removed the prostate from posterior while dissecting the seminal vesicle. Then he proceeded for the further dissection, and he could remove the prostate. He was a pediatric surgeon. He is very well versed to this anatomy, and the results of 3 patients were remarkable. They were 24 hours after the catheter removal. First 2 patients reported using single safety pad, and the third reported not needing any pad for the continence control. Finally, the second patient reported experience of a valid erection the morning after the catheter removal. So in 3 patients, these were the results which he published. But if you see the continence experience before Bouchardy, they were dismissal. Like you can see the level 4 studies, 65 to 80% were continented at 3 months. And when you stratified by the confounder, they were even worse at 36 months. So, and comparing different surgical technique, only bladder neck preservation was associated with the better results. But the bladder neck also is not very beneficial. So in that, one can say that there is no one magic trick or one maneuver that can actually helps in return of the continence. And also the potency was not very good before Bouchardy technique, and you can see in this slide. And then after the confound, when you stratify by the confounder, there was a very large effect, and that is why these techniques were there, but the results were different in different hands. And people, even for potency, they said one should keep away the surgeon and the heat, and this both thing can be achieved with the Bouchardy technique. So, and here, if you see the return of continence and a small safety liner in Bouchardy, that immediate continence results are 72.5%, and in first 100 patients, it was 80% in the next 100 patients. So these had been the results in our patients also, and the potency also was better than the anterior approach. And this is the main reason why I prefer this technique, especially in mostly selected patients. Even in the T3 lesion, you can offer this technique without compromising the survival outcome, as it has been shown here. So with that, I'll like to take any question. These are our results. I'll not go in detail. Anything anybody would like to ask me, because the time is short. I don't want to take any not much time for this.
Dr. Kostov, you are muted. Please unmute yourself.
I think that was an excellent insight. Any question for Dr. Raval? Any quick question?
Sir, Dr. Shailesh.
Yeah.
Please unmute.
Okay, Sri, I loved your talk. My question to you is, what according to you is the most important thing for continence? Does the neurovascular bundle sparing or not sparing have an important role to play in continence post-radical prostatectomy?
Sir, if you ask me about continence, it's a multifactorial. Neurovascular is one part, then the length of the urethra is another part, then the salvaging the bladder neck is another part, and the salvaging the anterior venous complex with the sphincter is both part. I don't think that Roca stitch helps at all. It just helps you in bringing the bladder to the to the urethra and facilitating the anastomosis.
So in a patient who has got a locally advanced disease and you do not try to spare the neurovascular bundle, his chances of continence coming back earlier is good or not good?
Sir, if you have taken out the neurovascular bundle, that doesn't mean that patient will become continent. He may take some time. That I agree, because the neurovascular bundle are important, but they are not the only factor for return of continence.
I agree there.
Yes, sir.
Thank you.
Dr. Gupta wanted to make any comment.
Next talk, Dr. Anurag Singla.
No, Dr. Sudhir, you have very nicely covered all the important development which have taken place after Moneyman and what he described actually. There are so many other things which you have not covered, like Vipul Patel is saying, some covering of the neurovascular bundle and all that, and cooling of the neurovascular bundle.
They have not actually made any difference.
I know most of the things are changing.
Yeah, they have used ice and all.
But very nice talk, very nicely summarized. For a beginner, I think so. This is very important thing to understand how much time it takes for any technique to evolve. Actually, Thank you very much.
Thank you, sir.
Lovely talk, Sudhir.
Thank you.
Thank you, sir.
So Dr. Dogra is here. So may I invite Dr. Anil Mandani to speak upon Rocco stitch and continence. Dr. Anil Mandani is a senior consultant urology and renal transplant surgery in Medanta Medicity, Gurgaon. Over to you, sir.
Yeah, hi, Prabhajot. Thank you.
Okay.
Pooja, you were supposed to screen my slides.
Pooja, are you here?
Okay, let me do it then. Yeah, good evening, everyone, and hope you all are doing well and have not fallen in love with corona. We all know that prostate cancer is a very intriguing subject, and as Dr. Raval already told, that Rocco stitch doesn't work. So I just want to rake up minds of so many stalwarts sitting in this forum, and I would love to bring in this topic, and particularly for youngsters, to think about the way we have been taught by people regarding recovery of continence and prostate cancer. So I'll just would like to bring your attention to the anatomy. You see, we know that outside the peritoneum, the fascia transversalis, which covers the prostate gland, and which we call it visceral and parietal endopelvic fascia, and the thickening on the same fascia is called puboprostatic and arcus tendineus. So these are the anterior support which are very crucial to the urethra. So let's talk about the posterior support, which is mainly related to the Rocco stitch. So if you recollect the anatomy, this is the peritoneum, and the Denonville fascia is supposed to be an extension of peritoneum which goes behind the bladder and the prostate, and it gets attached to the perineal body. Now this is the line diagram to make you understand the anatomy. So this is the Denonville fascia, this is the sagittal view. This is the sphincter. We know that this is a horseshoe-shaped sphincter which is attached to the median raphe. This is the fibrous structure from where this external sphincter originates. This median raphe is attached to the denonular fascia proximally or cranially, and distally it is attached to the perineal body. So this is the basic support to the sphincter, which gets weakened once you remove the prostate and destroy the posterior support and anterior facial support. This is the sagittal frontal view. This is the coronal view, sorry. So this is the denonular fascia. Imagine you have removed the prostate. What you are seeing is the denonular fascia attached to the median raphe, which is attached to the perineal body. So when we remove a prostate, we cut open the denon fascia twice, once at the bladder neck and another almost at the prostatic apex. So this is the bladder neck and this is the prostatic neck. So denonular fascia comes out with the prostate gland, and what you are left with the proximal part of the denonular fascia and the distal part attached to the median raphe, which indirectly attach to the perineal body. So what Rocco described in his open surgery was to take suture from this is the bladder lumen, 1 or 2 centimeter behind the lumen and to the perineal body, which is posterior to the urethra. But what I have done, I mean, as you saw in the picture, so instead of taking from the posterior part of the bladder, which anyway you are going to anastomose when you are doing urethrovesical anastomosis, you just bring in the posterior lip of the peritoneum. This gives a better support to the ureteropubic complex, because we know that when we are doing robotic or open radical prostatectomy, which is not Buchiari, which Dr. Rowell told us about the procedure, then you need to cut the anterior support. So the only thing which we need to reinforce sphincter is to give posterior support, and that is, I think, better would be when you stitch perineal body with the posterior lip of the peritoneum. So this is about the Rocco stitch, which he described in the open surgery. Now the beauty is, if you do Rocco or not, because probably the Money-Menon group proved that Rocco in randomized trial doesn't work, because the stitch was taken from the posterior part of the bladder, not with the peritoneum. In Rocco described 3 days continence to the tune of 72%. But if you look at the 30 days, I mean 30 days continence, it was around 80%. So the same thing was described in different ways. Like this was one of the articles which described all 3 kind of repair, like Rocco repair, Rocco stitch, then the urethrovesical anastomosis, then anterior reconstruction of the anterior facial support. So that means you are giving support to the urethral sphincter anteriorly and posteriorly both. And this is about the concept of Buchiari. When you go from behind, so what you are actually doing, you are not disturbing the anterior support, and what you are doing is going behind the prostate, and in this case you need to cut the posterior support. What I showed to you in line diagram, the cutting the denonular fascia, which is getting attached to the perineal body. So in Buchiari, posterior support is destroyed, but what you're left is with the anterior support. You don't touch the anterior support. That's the reason you have very good early continence in Buchiari. Now this is a very important comparative diagram, comparative cartoon or table. Like if you see the Rocco stitch performed by Rocco only, the Rocco gave us result of 72% continence at 3 days with 0 pad. And with Buchiari, there is no doubt early continence is the best with this procedure, because anterior support is not disturbed. So with Buchiari also, the zero pad continence at 7 days was 74%. And if you look at the ROCO, it was 72% at 3 days with zero pad. This is almost similar. But at 90 days, like Vip Patel, if you compare the data of Vip Patel did not demonstrate the advantage of ROCO stitch as Dr. Menon group did. So, but this ROCO stitch eventually at 90 days, whether you do ROCO stitch or you do Buchiari, the continence becomes the same at 90 days. So it's the early continence which is important in Buchiari. But unfortunately with Buchiari, which I think Dr. Rawal would like to comment, the margin positivity rate is very, very high. This procedure can only be done when you have a T1 disease or very localized prostate cancer. Because if you are dealing with T2 onward cancers or T3 cancers, margin positivity goes very, very high. So still we do not understand what determines the continence, but one thing is sure, if you are doing Buchiari, in select cases, your early continence is good, but continence at 90 days doesn't really matter if you are doing Buchiari or non-Buchiari. But I personally feel the way I do ROCO, I have got a good result. I mean, most of my patients, maybe I'll present my data in future because my number is not that great. Most of my patients are getting continent within a month. I would not say that within 3 days, 70 to 80% are continent, but continence has improved once I started taking stitch from the posterior lip of the peritoneum, which gives better support. So I'm open to any comment from the stalwarts or discussion on this. Thank you very much.
Thank you, Dr. Mandani, for excellent presentation on ROCO stitch. I have one question, sir. You said that we are excising the denominator fascia during prostatectomy.
Yeah.
But if we are doing intrafacial or interfacial nerve sparing radical prostatectomy, are we not leaving the denominator fascia with the patient, not over the specimen?
No, ideally, you see, interfacial and intrafacial are described in terms of lateral dissection. But when you go to posterior surface, I don't think you're leaving denominator fascia on the patient body.
Sir, we categorically we don't see the prerectal fat if we're doing the nerve sparing.
Yeah, maybe you are doing like that, but as far as the inter and intrafacial description goes, it goes with lateral dissection only. It doesn't describe about the denominator.
Okay, sir. Dr. Mallikarjun.
Anil, I just have one question.
Yes,
What
sir.
does the peritoneum do here? Do you need a peritoneum at all?
You see,
we are doing a posterior reconstruction, which
Uh-huh.
involves some amount of detrusor muscle posteriorly, denominal fascia, and the posterior fascia around the distal urethra. How does the peritoneum come into picture here?
Yeah, you see, as I said, the denominator, what is denominator fascia? When the peritoneum meet at the prostatorectal junction. So embryologically, denominator, if you read about the denominator fascia, it's an extension of peritoneal tissue which goes behind the bladder and prostate and gets attached to the perineal body.
Right. Anil, I understand, but basically getting the peritoneum down, will it cause a real reconstruction of the posterior? Because it has got a peritoneal surface which doesn't allow the fibrosis to happen there.
No,
So
you are providing support, initial support. You know, fibrosis eventually occurs and that gives support to the perineal body. But what you're doing is providing support to the perineal body by taking stitch so that you can have early continence.
No, I do ROCA stitch, but I don't take that peritoneum down because it appears
so
to
maybe you can try doing that in a couple of cases and see the difference.
Okay, can I ask something here, Anil? Dr. Raina here.
Sir.
I think what you're saying is right for only one reason, that you're ultimately you're getting the pelvic floor sutured. You're getting the pelvic floor in an angle. The moment you have got the pelvic floor organized, you're gaining your continence. That's what I feel.
One thing which I would like to say here, Anil, you said in Roca's hand it is 72% continence after
3 days, yeah, 0 pad, yes.
So the thing is that any technique which is replicable, that's the best technique.
True.
Problem with Roca is, as you know, that not only Mani Menon, there is another randomized control trial which has also shown that it does not help in return of early continence. Not only one, there are two actually. While with Bouchardy, they're not from Mani Menon. There are other groups also have claimed that the return of continence is faster. So that's actually, there is a definite difference between this. And then if you start doing Bouchardy, you will yourself will come to know that what the results are.
No, I'm not.
If it is replicable, then
yeah.
definitely, that technique is probably better.
No, there is no doubt. Bouchardy gives the base. Bouchardy gives the base to early continence. There is no question about it. But the only thing is a margin positivity. What is your experience?
That also improves. That was I was coming on. If you see the in literature now, the people are offering the same surgery, same technique, same approach for high risk prostate cancer. We are also doing. Only in very highly selective cases we convert to the anterior approach. So with the time it actually reduces.
So if you suture your puboprostatic ligaments after the prostatectomy, is that going to help you in your continence, you're saying?
Yeah, anterior reconstruction can help sometimes. I think it's a multifactorial thing. It's anterior, posterior, length of urethra, amount of muscle around the urethra, all factors which will play a role. I don't think we'll have one thing. Everything will support, possibly doing one. It's a combination of factors.
Absolutely. That's the whole continence mechanism there. I agree. Great.
People who have done without doing any suturing, putting a urethral catheter, pulling it up, and left it alone also had continence. So what stitch makes a difference or no stitch makes a difference? We don't know.
Yeah, it's all about early continence. Eventually, everybody is going to get continence. I mean,
I think the length of the urethra is the most important.
All factors. Perhaps. I don't say everything, only one. There's so many other factors.
So thank you very much for the Dr. Mandani for the
thank you very much.
Nice lecture.
Yeah.
So we move on to the next session. Dr. Anurag Singla, please introduce the next chairpersons.
Thank you, all the chairpersons and speakers.
Thank you.
Thank you very much for inviting us. Thank you.
Thank you, sir. So I would like to call the next set of chairpersons. Dr. C. Mallikarjun. He is a President-elect USI and Managing Director AI in Hyderabad. Dr. Rajiv TP. He is Consultant Urology in and Head of Department GMCH Medicity Guwahati and also Secretary USI. Dr. SP Yadav. He is Consultant Urologist in Pushpanjali Hospital. So I would request to please stick on time. We are already 45 minutes late. Thank you.
Yes, we'll stick on to time and sitting in the chair. Thank you very much for this nice introduction. And we have got two fantastic speakers who are going to be there with us. One is Dr. Sanjay Adla, my colleague in Hyderabad, and Dr. Vinita Goyal. I think Dr. Yadav will introduce her in the next talk. I think Sanjay has got a phenomenal ability to convince or deconvince you on any topic. He has got a fantastic talk also for his stature. That's neo-adjuvant approaches for high-risk prostate cancer. Sanjay, I think you can go ahead with it. Sanjay? Dr. Adla? I just saw you.
Okay, unmuting myself. You can hear me.
Please, thank you.
Thank you very much for the opportunity. I'll start off with this neoadjuvant approaches, which is quite a common practice, but not that very well understood, even with respect to radiotherapy. So let's look at what am I going to cover. I'm going to cover neoadjuvant treatment before radiotherapy, neoadjuvant treatment before RP, and what I'm not going to cover is regarding adjuvant radiotherapy, adjuvant hormone manipulation with radiotherapy, because that in itself is quite a large topic. That's why I'm not covering it. And when I'm going to specify low, intermediate, and high, there are almost 9 different risk stratification. But the DMECO, which was defined in 1998, is what I'm going to use whenever I'm commenting on high risk or intermediate risk prostate cancer. Let's look at neoadjuvant before radiotherapy. Does ADT work along with radiotherapy? Very commonly used, but we'll just try to see if there is any evidence for this. So the evidence started off quite early. It started off in 2001 when it was the first published, which was the RTOG 8610 study. And if you look at what it showed, it was from 1987 to 1991. So this was almost peri-PSA. In the PSA as such wasn't used that very often. And this was clinically, this was on digital rectal examination, locally advanced plus or minus lymph node involvement. And lymph node involvement was following PLND, which was done as a diagnostic set, or lymphangiograms. So quite a large cohort of patients, 456, and a follow-up of 6.7 years. And what they showed is when patients were randomized between neoadjuvant ADT plus radiotherapy versus just RT, there was better metastasis-free survival, better biochemical recurrence-free survival, local recurrence, as well as cancer-specific survival. And when they looked at a bit more closer, they actually commented saying that the outcomes were better in lower Gleason. But when you look at the specific numbers, they were quite small numbers for them to be commenting like that. So what it showed is a proof of principle saying that neoadjuvant ADT works along with radiotherapy. Then if it works, where does it work? Does it work in low, intermediate, or high? So this one quite often quoted paper from 2011, RTOG 9408, wherein what they did is neoadjuvant ADT plus RT versus RT. And this one was mainly for low and intermediate risk. 90% of the patients were low and intermediate. So there were only 10% of the patients which were high, and quite large, almost 2,000 patients. And what I'm going to try to make it clear is whenever I'm commenting as 4 months of neoadjuvant ADT, we are talking of 2 months before the patient starts having radiotherapy and 2 months while they are having radiotherapy. So neoadjuvant doesn't mean they just have it before radiotherapy and they did not have ADT during the time of radiotherapy. So this is neoadjuvant as well as concurrent for hormone manipulation. Median follow-up, quite good. And what they said is, first time showing better overall survival, and cancer-specific mortality was also halved when you use neoadjuvant ADT, and this we are talking of in low and intermediate risk. But when the subgroup analyzed, the benefit was only seen with respect to intermediate. So answering the first question, low risk do not need neoadjuvant ADT, intermediate risk 4 months of neoadjuvant along with RT is sufficient. How does it work? We know that there is a synergistic effect. And one of the common things that we see is that the prostate shrinks by around 30% by around 3 months. That allows better targeting and less toxicity. But a bit more complex than this is the effect of ADT. What it does is it decreases the hypoxia, thereby increasing the radiosensitization, increasing the cell apoptosis, decreasing the radio resistance. So ADT does tend to have a synergistic effect along with radiotherapy. So now that we know that it works, how long can I give? Can I give it for 2 years before I start RT? So this has been studied in quite a few studies. This one was a Canadian study, 3 months of neoadjuvant ADT versus 8 months of neoadjuvant ADT before RT. And one of the other things that it is, they risk stratified. They had low, intermediate, and high risk cohort of patients. And what they did is 3 months versus 8 months with a follow-up of almost 6.5 years, 7.5 years. And what they found is overall, there was no difference. Whether you gave them 3 months or 8 months, there was no difference with respect to overall cancer specific or biochemical recurrence-free survival. But they said the high risk cohort did better with 8 months. So now we are getting the numbers. Low risk do not need anything. Intermediate need 3. High risk need longer ADT. So high risk was studied in this Trans-Tasman radiation oncology group study. Very good numbers, 818. And what they did is radiotherapy versus 3 months of neoadjuvant ADT plus RT versus 6 months of neoadjuvant ADT plus RT. Equal distribution and 10 years of follow-up. What they showed is 3 months of neoadjuvant for high-risk prostate cancer improves the biochemical recurrence-free survival as well as local progression. However, if you want overall survival and cancer-specific survival advantage, you need 6 months of neoadjuvant. So again, we've got the numbers for high risk, you need 6 months of neoadjuvant. So 6 months of neoadjuvant would mean they had 4 months of neoadjuvant hormone manipulation and 2 months of concurrent when they're having the radiotherapy. Quite commonly we see in India wherein patients has the injection, Zoladex or whatever, and then they start having radiotherapy, which is what you will call as concurrent as well as adjuvant. So this was a study which was done neoadjuvant or adjuvant, which one is better? So in this sequencing, which was a phase 3 trial published in February 2020, the most recent study, Canadian study, what they did is 432, almost all of them were intermediate. So probably not the right selection of patient cohort. And they did neoadjuvant 6 months. So this was 4 months of neoadjuvant plus 2 months concurrent plus RT versus hormone manipulation started on the day of radiotherapy and then continued for 4 months further. Okay. And the current standard of radiotherapy was given, and at 12 years of follow-up, there was no difference in the biochemical recurrence-free survival or overall survival, suggesting that for intermediate risk, it doesn't matter whether you give neoadjuvant or adjuvant. There is another randomized control trial studying the same thing with RTOG trial, studying the same thing in high-risk prostate cancer, but the interpretation becomes very, very confusing because they had 4 different arms in that. So take-home messages from this: for the radiotherapy, ADT is required for intermediate, neoadjuvant or concurrent doesn't matter. Neoadjuvant ADT is better for high-risk prostate cancer. What about the more contentious neoadjuvant before RP? If you remember the numbers that I was quoting numbers in thousands or hundreds of patients. Whereas this meta-analysis, this was a Cochrane review of all randomized controlled trials published in 2009. And if you look at the numbers, 30 versus 30, 90 versus 71, the largest one, the Shulman one from 2000, was the largest one with 240 versus 240. And what it showed is when you give neoadjuvant hormone manipulation, ADT, surgical margin positive status is better, i.e. you have lesser chances of margin positive. However, the hard endpoints, disease-free survival, they are on the midline. Overall survival, they are on the midline, suggesting that yes, the pathological outcomes improve, but not the hard endpoints. So meta-analysis data is neoadjuvant ADT before RP improves the pathological outcomes, but not the survival outcomes. Whenever you don't have an RCT data, you look at a cohort study, MPACT, which is a large volume centers from Europe. They looked at 573 patients who had high-risk prostate cancer, comparing RP versus neoadjuvant ADT plus RP. And this was a retrospective study. Overall, around a third of the patients had adjuvant RT. And I'm going to take a bit of a minute here trying to make you understand this graph. So the best one is somebody who has neoadjuvant. So this is cancer-related death. The best outcomes are for patients who had neoadjuvant hormone manipulation, followed by radical prostatectomy, followed by adjuvant EBRT. Following that will be neoadjuvant hormone manipulation plus radical prostatectomy. Then comes radical prostatectomy. The one which is the outlier, which is the radical prostatectomy plus salvage radiotherapy or adjuvant radiotherapy, is an outlier because I think this was a selection bias here. This is the current standard that we use, which is radical prostatectomy followed by adjuvant radiotherapy. And what you see is that at 10 years, if you do the standard, which is radical prostatectomy plus adjuvant radiotherapy, the overall cancer-specific mortality is 19%. Whereas if you did the other way around, which is neoadjuvant ADT plus RP plus adjuvant RT, then the survival is 6. So you're almost decreasing by factors. Okay. So what is on the horizon? There are new molecules there. Abiraterone before RP. This is a phase 2 study. Very small number, 58 high-risk prostate cancer patients. So they compared abiraterone acetate plus LHRH versus LHRH, 12 weeks. And all the patients had all abiraterone after. So it was a bit of LHRH versus abiraterone. Then all the patients had abiraterone acetate. And what they found is, if you look at the numbers here, 10% of the patients who had LHRH agonist along with 24 weeks of abiraterone, 24, that's 6 months of abiraterone, 10% of complete cancer response, pathological complete response. Overall, there was almost around 52% patient who had good response. And the same was seen with respect to enzalutamide. Enzalutamide, before doing RP, phase 2 study, 48 intermediate as well as high risk patient, but they had a weird group, enzalutamide versus enzalutamide plus dutasteride plus LHRH. And then they went on to do radical prostatectomy. And what they found is overall around 74% of the patients have either complete response or maximal response. 2/3 of or 3/4 of the patient almost were cured. The last one, which is chemohormones, which has got a level 3 evidence published in Lancet, JETUC 12, chemohormone manipulation. So this one was 413 high-risk prostate cancer patients randomized between 3 years of ADT, 3 years of ADT plus 4 cycles of docetaxel with estromestine, and all the patients went on to have either radical prostatectomy or radical radiotherapy. And what they found is better recurrence-free survival, better event-free survival. Event-free survival was cancer-specific mortality as well as recurrence. And when you look at which cohort improves, almost all cohorts, whether lymph node positive, PSAs, as well as the only one that doesn't tend to respond is aggressive Gleason. So take home messages, evidence for ADT with usage of RT is very strong, level 1A. For intermediate risk, 3 months, whether you give neoadjuvant or adjuvant is sufficient. For high risk, I think it is better to do neoadjuvant for 6 months prior to RT. Neoadjuvant prior to RP has got 2B level of evidence, and there are quite a few new things on the horizon, including abiraterone, enzalutamide, and chemohormone manipulation. Thank you very much.
Very nice, Sanjay. I think you've very nicely concise the whole point. You've given an input about how much time to be given before RT. Is there any time limit for RP?
Minimum is
before RP?
Minimum is 3 months.
Minimum is 3 months.
Yeah.
Are you doing it routinely?
No.
Why so?
The reason is, if we are depending on what, if I'm trying to treat myself, which is I would like to have negative margins and a patient immediately happy following surgery, I would give ADT. We do not seem to have the hard outcomes, which is cancer specific mortality or overall survival being better. That's the reason I don't do it.
But
And we don't have an
message does show a definite level of evidence for that.
At least one randomized control trial to say that it is beneficial.
There was one, but the numbers was too small.
Yes.
It was very, very small. But anyway, the post neoadjuvant chemotherapy histological findings, which suggest which patient is going to do very well, I think that has correlated in long term after 10 years follow-up also, where the people have showed no disease or a very low volume disease have done extremely well when they had a long-term follow-up. Am I right?
Yes. Whenever we have had case series studies, which is level 2B we are talking of, we know that they do tend to well, but we have read papers, there is a huge amount of selection bias in these cohorts whenever we are doing observational studies. I'm sure we will be having evidence from the Stampede in the next 1 year, wherein adding abiraterone seems to make a huge difference. Right. I've seen the presentation, when I say presentation, when people have shared the slides without presenting them at the meeting, huge difference with ADT plus abiraterone before they went on to have radical prostatectomy.
Wonderful. The last question for you is, will it make your surgery anyway difficult?
We used to think that it would make it difficult. With the robotic technology where vision is the king, it doesn't make a difference.
No, it's not the vision alone. It's a question of you creating, saving the nerves and possibly creating a better outcomes at the end of the day.
I think saving the nerves is again treating the surgeon rather than the patient. These patients have been there for 6 months to 12 months, locally advanced prostate cancer. If I say that I've done bilateral nerve sparing surgery, I'm just fooling myself.
Okay, thank you, Sanjay. I think Dr. Yadav to...
Hello.
Dr. Yadav, yeah, we can
you see?
Yeah, go ahead.
Thank you, Dr. Rajiv. Thank you, Dr. Singla. I think we are already half an hour late. I should not take much time between you and the next speaker, Dr. Vinita. She's a consultant in Max Hospital. Dr. Vinita. Dr. Vinita, can you hear me? Dr. Goel, Vinita Goel.
You unmute yourself, ma'am. You unmute yourself.
I have unmuted, sir.
No, not you, sir, ma'am.
So you're audible to me. I'm just trying to share my slides. Give me a moment.
Okay, good. The topic is radiotherapy.
So are my
Does newer
slides visible
technology
to you?
help? Yes.
So good
Yes,
evening,
please
everyone,
go
and
ahead.
thank you, organizers, for having me here. And the mandate given to me is to speak about the role of radiation therapy for prostate cancer. The idea is to know, do newer technologies help, and which one to choose for which group of patients? To make you understand about what to choose for your patient, I will just go through all the technologies of radiation therapy and how they have evolved over a period of time. So in 1970s and 80s, we were doing conventional radiation therapy, where the radiation therapy portals were often decided by the bony landmarks rather than visualizing the prostate itself. So, and the dose of radiation therapy usually was in the range of 50 grays. And as a result of this low dose and bony landmark based conventional radiation therapy, majority patients had inadequate control of the disease. And the reason for that was inadequate radiation doses. There was uncertainty in localizing the tumor. We were often using large margins to overcome the uncertainties, and this translated into more toxicity. So overall, there was poor disease control and high toxicity. That came the era of three-dimensional conformal radiation therapy. Three-dimensional conformal radiation therapy was a big improvement in radiation therapy, because here we were deciding on the area of radiation based on the CT scans by identifying prostate, seminal vesicle, lymph nodes, etc., and then defining the radiation portal. So this is what a conformal, 3D conformal radiation looked like. There were 4 beams generally, one from APPA and 2 from the sides. And this is how the distribution looked like. It was much better than the conventional radiation therapy. And suddenly radiation oncologists started talking of dose escalation with controlled toxicity. So this was one such study which showed that patients who were given the dose in the range of 64 gray versus patients who were getting the dose in the range of 75 to 81 gray, the control rates were much higher in these patients with dose escalation. And this benefit of dose escalation in controlling the disease was seen across all groups, favorable, intermediate, and unfavorable risk groups. I would come back to this 3D conformal dose distribution once again. This is the zoomed view that I am trying to share. So this area, look at this area. So the distribution of 3D conformal radiation therapy was also squarish or rectangular in shape. And as a result, posterior wall of the bladder and the anterior wall of the rectum was still getting substantial dose, even with 3-dimensional conformal radiation therapy. Then came the era of IMRT, which almost came in 1990s, start of the 2000s, whereby we had a better diagnostic imaging like CT scans, MRI, PET scans to identify the tumor and the disease. And our linear accelerators also had a lot of improvement in their hardwares and softwares. So this is what is called as multi-leaf collimators. These collimators help us shape the beam of radiation according to the shape of the target rather than keeping it square or triangular. There were better softwares, there were better planning systems also, which together help us modulate intensity of radiation beam. So we could modify or change the intensity of radiation beam, and this is called as IMRT or intensity modulated radiation therapy. I'm going a little slow in my presentation because I know that the majority audience are urologists and non-radiation oncologists. So I'm just, making an attempt to make you understand our perspective. So this is actually a simple line diagram, which is showing this pink box is showing the dose distribution. So in conformal radiation therapy, even when we were treating prostate, a lot of rectum was getting the dose. But with IMRT, we could modulate intensity of radiation, and the radiation beams were tightly hugging prostate or the desired target without unduly radiating the rectum or the bladder. So the treatment was becoming more effective, more focused, and more precise. So just to show you another example, for example, these are the areas of lymphatics. If I have to treat this patient with 3D conformal radiation therapy, my dose distribution, radiation dose distribution be something like this. But with IMRT, I will be able to generate something like concave dose distribution and completely spare out the bowel to reduce the toxicity. Now, this is another example. This screenshot is showing the low dose distribution using 3D conformal radiation therapy in IMRT. So look at the doses or doses to the rectum. Here, the whole circumference of the rectum is getting radiated, while here, a majority of the rectum and bladder are getting spared with the use of IMRT. Next addition that we got was image-guided radiation therapy, which is a combination of IMRT with image guidance. So this is how the typical modern linear accelerator looks like. This is actually a cone beam CT scan, which is mounted on the linear accelerator on a robotic arm. So once the patient is ready and positioned on this couch for treatment, then before starting the treatment, machine takes a CBCT or cone beam CT scan of the patient, which is matched against the planning scan. So this image is actually showing fusion of the two scans. This is the planning scan, and this is the CBCT scan, which is acquired on the machine before starting the treatment to verify the position of the prostate, bony landmarks, bladder, rectum, etc., to ensure that the radiation is just delivered just spot on. So because we know that in prostate cancer, there can be differences in bladder and rectum position as well as filling. So this CBCT or IGRT gave us confidence to reduce our margins around prostate from 10 millimeter to 3 to 4 millimeter. So ideally, every IMRT should be combined with IGRT. In addition, we also have hexapod robotic couches on our linear accelerator. So if the patient is slightly rotated on the day of treatment, the machine identifies it and corrects the positioning of the patient without moving the patient, machine or the couch rotates. So this all translated into this kind of control rate. This is a study from 2008, which is showing that with the present type of radiation therapy with IMRT and IGRT for low risk prostate cancer, the control rates are almost 100%. For intermediate risk, it is around 80%. And for high risk, they are about 70% and with very less toxicity. So radiation beams have become sharper, focused, more precise. And this made radiation oncologists like me feel more empowered in safe delivery of radiation therapy. And we moved on to stereotactic radiation therapy for prostate cancer. Stereotaxy is a concept which is derived from stereotactic radiation therapy for brain tumors. Usually earlier it was done for using gamma knife, and now it is being extended for extracranial or outside brain targets also. So if I talk of indications of using SPRT in carcinoma prostate, it is indicated for all low and intermediate risk carcinoma prostate, where the SPRT is done for prostate, and also in oligometastatic situation, where it is directed towards either metastasis or prostate. I'll show you by a few examples. For example, this is a typical dose distribution of SPRT, where you can see that the dose is hardly spilling into bladder and rectum. This is the low dose pill that I'm showing you. And this dose is delivered over just 5 fractions rather than 5 to 7 weeks of radiation therapy. So this is a comparison of IMRT versus SPRT. And as you can see that even the low dose spillage is much less in SPRT as compared to IMRT. This gentleman, he had completed his treatment using adjuvant hormonal therapy and radiation therapy for prostate cancer. And about 2.5 years later, he had a small recurrence detected with the rise of PSA and picked up on a PSMA PET scan. We treated this patient with an ablative dose of radiation being directed to this metastasis with a radical intent. Similarly, when we get patients with oligometastatic bony metastasis or spine metastasis, now it is possible to give them high dose of radiation therapy, ablative dose of radiation therapy to control their metastasis while sparing the spinal cord. So here, as you can see, the hardly any dose is going to the spinal cord, but the dose is being focused only on the vertebral metastasis. And when we talk of techniques, we should not and we cannot afford to forget about brachytherapy, which is still the most conformal technique of radiation therapy. There are 2 ways of doing prostate brachytherapy, either using LDR iodine seeds, permanent seeds, or HDR needles. And it is a very effective form of radiation therapy. Recently, one trial was published which compared in high-risk prostate cancer dose escalation using brachytherapy versus external RT, and which clearly showed that using LDR seed implant brachytherapy was much better than using external RT. But I have been realizing that there has been a declining use of brachytherapy in prostate cancer, even in the academic centers. This is the data not from India, but from US, which is also showing that there is a declining use of prostatic brachytherapy because of it being an invasive procedure. If I talk of India, I will say that as a radiation oncologist, we are all trained to do brachytherapy because cervical carcinoma is one of the major carcinomas in India. Why we do not do prostate brachytherapy is generally because of lack of availability of iodine seeds and lack of training at the post-graduation level while we are trained to do brachytherapy. I will quickly come to two last techniques of radiation therapy. One is CyberKnife. CyberKnife, a lot of you want to know what is CyberKnife, is a linear accelerator which is mounted on a robotic arm. Because it is mounted on a robotic arm, it has much higher degree of freedom to deliver radiation from all the sides. I will just skip this comparison. If I have to summarize the role of some CyberKnife in carcinoma prostate, I will say for SPRT, there is some minor additional benefit with use of CyberKnife in comparison to the conventional linear accelerator, introducing the doses to bladder and rectum. For intermediate and high risk prostate cancer, there is no additional benefit. The new kid on the block is the proton therapy. We have one machine in India at Apollo Chennai, and there are small studies which have compared IMRT with proton and photon and have shown some advantage in terms of dose reduction to prostate and bladder. However, cost and availability of machine is still a concern. This is the distribution of proton therapy versus IMRT. So this purple colored cloud is showing you that the dose to the bladder and rectum gets further reduced in protons as compared to chromotherapy. Another last thing from my side is the use of space OAR, whereby through transperineal route, we inject a gel between the prostate and the rectum to create a space so that we can further reduce the doses to the rectum. And this is how it looks like in the MRI picture. So if I have to give you the take-home message, I will say that the standard minimum technique for prostate radiation therapy is with intensity modulated IGRT. It can be delivered with any type of linear accelerator. It can be a C-shaped linear accelerator or chromotherapy or CyberKnife. For high-risk prostate cancer, the standard of care is to give 4 to 5 weeks of radiation therapy. And for low and intermediate risk, radiation is directed only to the prostate and seminal vesicles, either with IGRT over 4 weeks or using SPRT over 2 weeks. And oligometastases are treated with SPRT. For proton therapy, there is no additional benefit in terms of local control rate. It does help in reducing the low-grade toxicity. The cost effectiveness is still not known. Brachytherapy is a very promising therapy. It has a role to boost in high-risk carcinoma prostate as well as monotherapy in low-risk prostate cancer, but the question is of availability and expertise. Space OAR is promising, expensive, and presently not available in India. Many thanks to all of you for your patience.
Dr. Yadav, you have to unmute. Yadav sir, unmute yourself.
So,
yep.
Sir,
you are audible.
Thank you very much, sir. Already we are late. Any question?
Ma'am, there was a question on the chat. How much will be the doses of radiotherapy?
So which case? So if it is low-risk prostate SPRT, is low-risk prostate cancer, then we would generally do SPRT to the dose of 35 to 40 gray in 5 fractions. If it is intermediate and high-risk prostate cancer, usually the dose is 60 gray in 20 fractions.
For how many days, madam? For how many days?
4 to 6 weeks. 4 weeks is the optimum.
Alternate day.
So SPRT is alternate day, but when we are giving 60 gray in 20 fractions, then it is 5 days in a week, every day.
Ma'am, one question from my side that a lot of people, a lot of patients after 5-6 years, then they complain a lot of problems. Why after 5-6 years?
So with the present technology of IMRT and IGRT, even when we have a follow-up of 5 to 10 years, we are not seeing so many complications. You have to understand the way your surgeries have evolved, radiation also has evolved and become more precise. I'm hardly seeing any proctitis or cystitis. I see proctitis and cystitis in my cervical carcinoma patients, but not in my prostate cancer patients.
Urethra become very tight. Urethra become very tight after 5-6 years.
So the urethral strictures is a problem when we have to give radiation after your surgery, not in the upfront. That is why I don't like post-operative radiation therapy.
Okay. Thank you, ma'am. Any question, Dr. Malik?
No, I think that's enough. Possibly we'll shift on to the next session because it's already late. In fact, we are reaching the closing time.
Thank you very much.
Thank you, Dr.
Thank you, Dr.
Thank you. Wonderful talk.
Thank you all the chairperson and speakers. Now we will be going to the panel discussion. The topic is the treatment of high-risk non-metastatic prostate cancer. To invite Dr. Kishore PA, who will be the moderator for this panel discussion. He is a consultant in Aster Medicity Hospital, Kochi. And now I would like to invite my the panelist also, Dr. Hemant Tangaonkar. Is consultant surgical oncology and urological oncology in PD Hinduja Hospital, Mumbai. Dr. N.K. Mohanty, he is consultant urologist in Dios Hospital, Delhi. Dr. Raghunath S.K., he is a uro-oncologist and robotic surgeon and director in Trustwell Hospital and HCG, Bangalore. Dr. Anup Kumar, he is professor and head, urology and renal transplant, VMMC and Safdarjung Hospital. Dr. Gagan Prakash, he is a professor in urological oncology in Tata Memorial Hospital, Mumbai. Dr. Sarupa Mitra, she is a senior consultant radiation oncologist and chief unit of GI and GU services, Rajiv Cancer Institute, New Delhi. Dr. Vikas Talreja is a consultant specialist in Department of Medical Oncology and Hematology, Safdarjung Hospital. Dr. Kanika Sood, she is a clinical lead and senior consultant radiation oncology, Dharamshila Narayana Super Specialty Hospital, New Delhi. Yeah, Dr. Kishore,
Thanks for the kind introduction. So we have a whole bunch of uro-oncologists and with a couple of radiation oncologists and medical oncologists in the panel. So most of these cases are from real life scenarios. So I'm going to start with the first case. So again, it's a non-metastatic case. All of the cases are non-metastatic. So it's a 51-year-old patient who is a sexually active male with minimal LUTs. He's a teacher by profession. It has got bilateral firm prostate. And his PSA is 91. And the biopsy was performed and it was showed like all cores were positive, lesion 7. So Mohanty sir, you can hear me? Sir, you can hear me, Dr. Mohanty? Sir? Hello? Hello, sir?
Dr. Mohanty, unmute yourself. Yes.
Okay, can you hear me? Hello? Hello, sir? Okay, then I'll just switch the questions to Hemant sir, okay? Yeah. So you've seen it all, you've been through the open area like in the 1980s and 90s where you're doing mostly open radical prostatectomy. And you used to give a lot of emphasis for clinical staging. So we always say T2 and T3 while doing a clinical staging, but is it really possible to address this? Like whether you can identify between a T2 disease and a T3 disease, sir?
Oh, you can a gross T2 and a gross T3, something which has got a gross T3, that is a gross disease outside the prostate. Yes, you can identify by a DRE, but those who have just a subtle extraprostatic extension, you can't make out by DRE at all. I think these patients, when you're contemplating surgery, need an MRI, MP MRI, definitely, no question about it.
And what do you feel? Like, say, if you were in the open prostatectomy, would you take him for an open prostatectomy at that point, open radical, like maybe a decade back or 2 decades back before? Would you consider
a radical prostatectomy for what? I didn't get your question.
For a PSA of 91, you would have considered for an open radical prostatectomy a couple of decades before, or would you send him for other treatments?
It's not only the PSA which matters, the clinical stage also matters along with that. And what is the Gleason? Okay. Then you have to consider all these 3 factors together and then make a decision. I would have considered if it's an organ confined disease, okay, I would still consider, no question.
So my question would be, as the emergence of robotics have changed the surgical paradigm in high-risk prostate cancer, do you think so?
It has, it certainly has, because, it's not just the robotic technology, but it is also that we are doing more MRIs. We know the exact extent of the disease. We are able to choose patients, T3 patients who are suitable for a radical prostatectomy. And yes, the precision is definitely better with a robotic technology, no question about it. So more and more patients you can choose better and do a better job along with a robotic technology, no question.
Mohanty sir, you can hear me now? Sir? Okay, so I will go to Dr. Raghunath then, so he's still not around. So, no, he has got a like a PSMA PET scan which is showing a diffused uptake in the prostate. There are no nodes, no metastasis, and MRI also shows bilateral diffuse disease. So, Dr. Raghunath, given a choice, no, which investigation would you do on a PSA of 91 and a biopsy like all cause positive? Would you straight away go for PSMA PET or you do both?
I would directly go for a PSMA PET scan. If it is negative for metastasis, probably I would investigate, as you investigated in this particular case, MRI, to understand the T status better with MRI than PSMA PET scan.
And how often in your practice that a PSMA PET scan gets it correct, like the sensitivity and specificity?
I would not say 100%, but at least that is the best available modality as of now in India or globally to understand the metastatic disease burden.
And do you have experience in Bangalore with the PSMA PET scan, PSMA PET MRI?
We do have at our place. Generally, we combine PSMA PET scan and MRI in this kind of cases where it is localized or locally advanced prostate cancer there. If it is a old metastatic disease, probably we avoid doing MRI. Otherwise, we combine both in this kind of cases.
Okay. So, Dr. Anup, you're there?
Yeah.
Yeah, so we have seen you doing a lot of advanced prostate cancers, both 3D laparoscopic and robotic through the webcast, and also would you do a like if the PET scan is negative and MRI shows a definitely diffuse disease, would you go ahead and do a prostatectomy for him, either laparoscopic or robotic?
Yeah, so this is a case of high risk localized prostate cancer. So as per the guidelines, he's a candidate for multimodality treatment. So my option will be to go for radical prostatectomy first. Definitely robotic is better than the open in this patient. And then depending upon the histopathology, we'll give adjuvant treatment later on. So we are dealing with these patients for many years now, and we have got many good results. So I think that's my first choice, to do the robotic radical prostatectomy in this patient.
How good is the continence and other parameters?
Yeah. So the continence and the erectile function, we have compared with our other group, which is localized and intermediate risk, and they're almost comparable. So I don't see any difference except when the disease is locally advanced, and there definitely erectile function will be compromised, but still the continence will be good.
And Gagan, Dr. Gagan is there?
Yeah, hi, sure.
So is there a cutoff point for you in PSA? Say, if you have a person with a PSA of 180 and there is no mets in PSMA PET scan, would you still go with radical prostate, or would you say, this is my upper limit?
See, these are outliers. It's not a very common scenario that you would see a totally unconfined, not so high Gleason and still the PSA is so high. So we would want to see if there is something in the imaging on the clinical scenario which can explain a PSA which is more than what you would expect for this kind of a disease. If you can find some other reason, like say if it's a humongous prostate or recurrent UTIs in the past, or there's been high residue, something which can explain a high PSA, then that's fine. If not, then we would consider that this high PSA is going to show up sometime in the disease later on. Unfortunately, I don't think there is a cutoff to say that. The decision for whether to operate or no, which as Dr. Tungawkar mentioned, would be a more considering not just the PSA but the other factors as well. I'm not sure if there is a PSA cutoff that we can mention here.
Dr. Kanika, would you ask the surgeon to go ahead first in this case, or would you go ahead with a neoadjuvant hormone and an RT for him, 51-year-old?
Yeah, so heavily weighed against a lot of urologists. So see, as per the guidelines, we in our practice still tend to follow the NCCN guidelines, and ADT followed by radiation remains the category 1 indication as of now. Yes, if there is a patient who has severe IPSS issues and not fixed disease, one might consider, but I think I would prefer doing an NAHT in this patient, because PSA of 90 does indicate there might be which may, prop up later on, because anything above 20, we all know there is some risk of micrometastasis in the body. We may not be able to prove it with PSMA because PSMA also has its share of some problems. We don't have 100% sensitivity. So given a choice, I think I would prefer to start off the neoadjuvant hormone therapy.
And does the age matters for you? Like a 51-year-old, would you still go ahead with radiation, or does that change?
So I think age does matter, and if you are considering the side effects with the technology which we have now, with MRI-based contouring, with the strict bladder and bowel protocols, and with onboard imaging daily, I think the amount of toxicities have gone down. So I would not be, boasting in saying that I am compiling data of last 7 years of moderate hyperfractionation of prostate cancer. I just have one case of radiation proctitis in my kitty. So we have that confidence now with the technology we have, the understanding we have. We've stopped treating nodal stations in so many patients. So there is a big, transformation in the radiation in the last 5-7 years, which has, brought in the confidence that yes, even for a 51-year-old, we can offer neoadjuvant followed by radiation.
Dr. Swarupa, you're there?
Yeah, yes, I'm here.
Yeah,
so I agree with Dr. Kanika that this is a patient post-surgery. If he were to undergo surgery, he will land up with radiation sometime or the other, and very soon. So it is better, I would prefer that we give him a neoadjuvant hormone therapy followed by concomitant hormone therapy, radiotherapy, and adjuvant hormone therapy for about 3 years. And if you're talking about the side effects, yeah, I agree with Dr. Kanika. These days, we have seen very, very less number of proctitis or even cystitis. And if you're talking about erectile dysfunction, that too, I think the number have dwindled quite a lot. So I would go for neoadjuvant hormone therapy followed by radiotherapy and hormone therapy.
And I just add erectile dysfunction, it is just not dependent upon the radiation. There are other factors. ADT might be detrimental. The patient has some diabetes. These are some other factors which can also be adding on to erectile dysfunction. So we should take into consideration all the factors, just not the radiation, because even in radiation, we are trying to protect the penile bulb to the maximum. There are strict guidelines which we follow in current day radiation practices.
I think from radiation oncologist perspective, I mean, they don't like to give post-operative radiation, post-RP radiation. So what are your concerns in that? I mean, you'd like to get a fresh case always. So, Dr. Kanika.
Yeah. So as I think Dr. Vinita also shared her peace of mind, when patients come post RP, first of all, it takes time for the continence to come. We cannot start radiation till the time patient at least gets a reasonable degree of continence. And our toxicity levels tend to be higher in post-op settings because that is the time when you are likely to have, a lot of seromas there, and sometimes the bladder capacity of the patient is less. So patient cannot hold urine. So the small bowel tends to come into the pelvis. So you add to the toxicity, and that is the time when you are to go right to the apex. The saving of the penile bulb gets less when you're treating post-op because the guidelines tell you that you have to go right to the apex. So to the covering the apex, you tend to deliver dose to the penile bulb. So your outcomes definitely go down when you're doing it in adjuvant setting comparison to when you're doing it in a radical setting.
And even the radiation gets delayed many times. The incontinence takes so long time. We have seen 1 year, 1.5 years, and the patient is awaiting a radiation with the PSA rising. So it gets delayed also many times.
So this was the PET scan of the patient, and this was his MRI. So unfortunately, he underwent the RARP because it landed up with me. So I did a radical prostate for him. So in fact, he had seen like a medical oncologist a couple of days prior to that. So he received a hormone treatment, even though it's not a usual practice. So he had received a lupriolide, about 22.5, but it was just a couple of days before the surgery. So the pathology report was PT3 disease with seminal vesicle invasion, extraprostatic extension, multiple margins positive. It was a Gleason fold with a tertiary pattern of 5. So Dr. Vikas, you're there?
Yeah, hi.
Yeah. So this is a tertiary pattern 5. Would it change any treatment pattern for you? Would you be like really averse of that, or would you just shrug it off?
So there are various factors for predicting the local control as well as the systemic control. probably in a, it could be a predictive pattern, but I don't think so it's a prognostic pattern right now. So for me, it doesn't change much significance, but yes, I will be waiting a bit for the results for what it is.
Okay. So coming back to Dr. Mohanty, you're there, sir? Sir? I think we're missing him, so sorry about that. So Hemant, sir, you're there?
Yeah, very much.
So, so we have now a situation where, like we had the patient have received the neoadjuvant hormone therapy,
Yes.
and we have multiple margins positive young patient, and at 1 month his PSA is like almost 0.017. So, what is your thoughts on the PSA level after radical prostate? Do you do ultra-sensitive PSA, or do you rely on the old mark of 0.2 for any treatment to start with, or you just start earlier than that?
See, the question here is, first of all, this patient has multiple high-risk factors on the histopathology. See, whenever you're talking about radical prostatectomy for locally advanced prostate cancer, you need to select out this patient. Now, I don't know whether the MRI showed that there was extra seminal vesicle involvement, etc. Secondly, what about the lymph nodes? Were the lymph nodes positive? There's no mention of lymph nodes here.
The lymph nodes were negative.
Or negative. So an extended lymphadenectomy was done.
Yes.
And such radical prostatectomy should only be done by experts. Otherwise, you'll get these multiple margins positive, etc. Here, I think you should do a ultra-sensitive PSA, but I still follow this thing of 0.2. That PSA failure after radical prostatectomy, I still follow the age-old thing of limit of 0.2.
Dr. Raghunath, would you have the same criteria, or would you choose something different regarding the PSA before you start the treatment?
0.2 is the criteria as per the literature, but in high-risk patients, now there is some evidence to say that even 0.15 rising trend, we should consider early salvage radiotherapy, but there is no level 1 evidence for 0.15. Only in high-risk patients, we do consider, on case-to-case basis, we start adjuvant or early salvage radiotherapy.
Gagan, which is your preference? You prefer like salvage or overall, not for this case, salvage or an adjuvant one?
So I think we are in the transition of pre and post radicals results. Now, theoretically by the radicals, we would want to wait for the PSA to reach up to that value of 0.2. But I think what we don't know is that when multiple of these factors are positive, in this patient, the seminal vesicles involved, there's extra prostate extension, there are multiple margins positive, and there's an upgradation of Gleason's. I think there are enough things to say that this patient is likely to have, problems later on. I might be a little more inclined towards, an adjuvant radiotherapy, despite knowing about the radicals. I'm not sure if, when multiple such adverse factors are there, do we still follow radicals or no?
I agree with Gagan. Huh? This is absolutely right.
So Anup, how long will you wait? The patient is still incontinent. He uses one pad at the end of 3 months, and his PSA is slightly rising. PSA at 3 months is 0.019. So would you wait till the continence is recovered, or would you go send him for radiation right now?
So PSA is almost 0.2 now. 0.19, so it is near 0.2. I would like to repeat a PSA PET scan, and would like to see, because almost 3 months now have passed. So there might be some metastases, which are micrometastases, which have come up now. And even if the micrometastases are not there on PSMA PET scan, I will refer this patient for the adjuvant radiotherapy and ADT, because he has already attained one pad continence. So I will not wait further. I will refer him for the radiation and ADT.
Sir, Mohanty sir, you're there. You can hear me, sir, now?
Yeah, I can hear you.
Okay, perfect, sir. So, in your practice, do you do PSMA scan regularly in the post-op setting? How often you pick up the cases?
See, we regularly do a PSMA PET scan prior to surgery, prior to giving any treatment, to see what is the basic position, whether he has METs, he doesn't have a MET. And then after a year of giving the therapy, either it is surgery, radiotherapy, or combined with androgen therapy, we do a repeat PET scan to see how much regression has taken place or progression has taken place.
Okay. So basically all the urologists have concurred will go for a adjuvant radiation. So my question to radiation oncologists is that when they will take and when they will start the neoadjuvant therapy for this patient, hormone treatment. Dr. Kanika?
So I think there is a consensus, and I also agree to the fact that this the radicals as well as the meta-analysis has not guided us in case selection. It is surely telling us that we might be able to avoid adjuvant radiation in a good number of patients, but still the black and white definition of which is that patient which should go towards the weight versus the salvage versus adjuvant has been clearly defined. Surely the molecular decipher and all would be the answer in the future, maybe, and then the long-term result. So since there are multiple factors, and beautifully you put the tertiary grade 5 also present, which is an independent factor for biochemical recurrence to happen. So there is no doubt that there are multiple factors which would be portending that there could be disease failure later on, but urinary continence has to be achieved. So we can wait as late as up to even 6 months in some situations, because continence has to be achieved, because when you're using the current radiation techniques, you have to have the patient hold the bladder for a while during treatment. So at least a 250 to 300 cc, if bladder holding capacity comes, that is the time we can start off our treatment.
And Dr. Swarupa, how often the incontinence worsens after radiation?
Yeah, no, see, this is the kind of patient I was talking about, and I'm really worried about this kind of a patient, because you can see all seminal vesicle invasion, multiple margins positive. So I'm really worried that I should be able to give him radiation at the right time, and with the PSA rising so fast, and yet the incontinence is persisting. So, but seeing these conditions, I would probably wait for another 3 months for another PSA. And then if the continence probably will be better, so because now it is one pad incursion, it will probably be better. Then I would do a PSMA scan before planning for a local radiation, and then probably go for the local radiotherapy along with the hormones.
Dr. Kanika, have you do you do regularly the PSMA PET scans when you have a recurrence after radiation, and how often you find it in the prostate when you do the PSMA PET?
Yes, by and large, what happens is patient actually walk to us with a PSA because the reference comes to us when already there's a rising trend of PSA. And if I am doing a planned adjuvant, I would rather prefer after a systemic workup, I would require a multiparametric MRI definitely, because at least from the planning perspective, the PSMA PET does not give me spatial information in context to my planning contours. So even if I do it for metastatic workup, I would join it with an MRI. Better define me the radiation protocols.
So I think here the patient underwent radiation and is doing now fine actually. Underwent the radiation in H1 hormone, is completed 2 years, is still not recurred biochemically. So go to the second case. So it's again a young man, again 54-year-old. His PSA is 38, it's not as high, but his PSMA PET scan shows bilateral tiny lymph nodes. He has also a history of recent angioplasty for a single vessel disease, and he has again a Gleason 7 disease with 8 out of 2 cause positive. There's history of bilateral hernia repair. These are the prostate uptake. This is the node uptake at the pelvis. So, sir, during the Mohanty sir, can you hear me?
Yeah.
Earlier days, the lymph nodes were used to be a contraindication. People used to do, say, lymphadenectomy first, and lymph nodes comes out to be positive. They used to abandon the radical prostate. No, has the paradigm changed? Has the the philosophy of the prostate cancer management changed accordingly over the years?
Yeah, because you see, he's a young gentleman, 54 years. The only problem is that he has a coronary artery disease with some stenting, and PSMA shows tiny lymph nodes. We don't know whether it is metastatic or not. In such cases, it's oligometastasis disease. If we consider it, I think so. With good cardiac control, he can go for a radical prostatectomy, my first choice, and see what the biopsy shows.
So Hemant sir, Dr. Mohanty would like to go to radical prostate. So would you concur with that? And what will be the extent of your lymph node dissection if that's the case?
Well, the benefit of radical prostatectomy for patients who have clinical node positive is not really proven. And that is why, I would probably counsel the patient, discuss the options entirely, not just the surgery, but surgery. This patient will also require adjuvant hormone therapy, or the other option of only hormone therapy with radiation. I will discuss with the patient, then make a decision. But if he is 51 years old, I would definitely tend, my decision will be more in favor of radical prostatectomy, and I would do an extended lymph node dissection, not a standard lymph node dissection. For all high risk patients, I would do an extended lymph node dissection.
Okay. So, Dr. Vikas, this patient has got a single vessel disease. Would that change your management regarding the hormone therapy? Would you go for Ligarelix because it's cardiac disease?
Probably yes, but I suppose you took the word out of my mouth and you conveyed it in a beautiful manner that we'll go for the cardio-friendly drugs rather than the traditional hormonal agents. Yes, definitely.
And you continue it even if it is monthly, you continue it. I mean, even for metastatic prostate cancer, you do.
Yes. In later lines when we go, we'll discuss the options which we have in the bioselections. But right now, yes, we'll go for the same.
And Dr. Raghunath, how much would be the extent of the nodes actually for him for this patient? Would you do till up to what level would you do there?
No, at least I would do till the crossing of the ureter. And sometimes in this kind of cases where clinically node positive disease is there, we may go up to common iliac lymph nodes. Though there is no proof to say that by doing common iliac lymph nodes, you are going to improve the survival. But definitely I would do in this particular case, because already clinically node positivity is there. I go one step higher and probably clear all the nodes up to the common iliac group of lymph nodes, which is not technically very difficult with robotic surgery.
Okay. And Anup, would you do the same?
Yeah, so my philosophy is that if we find a lymph node at one particular level, we have to go one level higher than that. Unless we clear that higher level, the surgery is not oncologically efficient. So as in this case, we have shown only one tiny lymph node on each side. If we go up to the common iliac bifurcation, as Dr. Raghunath has said, we are actually clearing most of the lymph nodes. And then we have to understand one more thing. Even if the one single lymph node comes out positive in histopathology, still we can observe this patient as per the latest guidelines. And if the lymph node is less one and it is not extra capsular extension, you can still observe this patient is no need for adjuvant radiation. So I will still go for, as you said, robotic prostatectomy with extended lymph node dissection up to the common iliac bifurcation.
Dr. Gagan, would you be able to give a choice to the patient, like say, I'm going to remove all the lymph node, all the positive lymph node. Is it possible with an extended node dissection, or still you can leave one or two lymph nodes behind? Do you feel, are you confident enough, like in a way, to remove all the positive lymph nodes seen in the PSMA PET scan? No templates?
Difficult to say. Yeah, I think it would largely depend on the surgeon's experience, vision, and my personal experience with robotic hasn't been that much compared to the amount I've spent in the pelvis, including cystectomy and prostates. I think the amount of clearance which I can do in an open surgery would probably be more compared to robotic, because the sheer numbers, including the cystectomies also. Whether assuring that every single lymph node which is seen on the scan will be removed surgically, no, I think it's totally a surgeon dependent thing. We obviously would want to
make an alteration
in the template.
Would you make an alteration in the template? Would you incorporate presacral nodes or?
Yes, of course, yeah. So typically areas like the presacral areas which are around the obturator nerve or behind the obturator nerve are the areas which are where we often tend to miss out the nodes. And because this patient is likely, or at least on the scan looks like a clinically node positive patient, I would want to specifically look into those areas.
So again, the patient had a radical prostate, his margins were negative. There was seminal vesicle invasion, extra prostatic extension were present. 4 nodes were present. So I thought I took out all the nodes. It was again a Gleason 7. It was not really high grade. But the surprise came, the first 6 weeks PSA was 7.15. So Dr. Kanika, would you do RT for him? Would you do a PET scan, or would you go ahead a hormone plus RT for him?
Particular patient, I think a PSMA PET scan is definitely warranted, because with the nodal disease and with seminal vesicle involvement, there are more chances of distant metastasis. So the importance of ADT comes first. I think ADT is the most important element in his treatment. Since the nodes are more than 2, then that is the indication where additional radiation can be added. Had he had just less than 2 nodes, I would have maybe kept him on ADT itself.
So, Dr. Swarupa, would you deem him as a metastatic case, or even if the PSMA PET is normal, or would you do a radiation for
This is again a patient who is not going to do well. So I would go, looking at 7.15, I would definitely go for a PSMA PET, and then looking at the nodes, number of nodes, he needs 2 pads still. So hormone therapy, I would like to start the hormone therapy immediately, and then radiation therapy can be added once the continence is better.
Okay, so if PSMA is normal, what would you do in this case?
Even then, I think the hormone therapy has to be added.
Just hormone therapy.
So Dr.
Hormone therapy will be added, but because of the pads, number of the incontinence, I would not like to add radiation right now.
Dr. Kishore, this is Dr. Rajiv Sood here. And I think if we can wind up the case, because this metastatic in detail tomorrow we are going to discuss. And time is already. Thank you.
So I think, so I think that's fine. So I thank all the panelists on my behalf and the organizers' behalf. And I think I'll pass over to Dr. Anurag. Thank you. Good night.
Thank you. Thank you, Doctor.
Thank you, all the panelists and Dr. Kishore. Now, due to unknown reasons, the next debate is not happening. And I would like to call Dr. Malikarjun for the closing remarks. Is he available?
Dr. Anurag, the next debate is tomorrow.
Yes, sir. Okay, sir. So I would like to call Dr. Sood for closing remarks, as Dr. Malikarjun has some work.
Fine, thank you.
No, Dr. Malikarjun is there.
No,
he's there.
I might be leaving. That's the reason. I was just watching it. I could not resist. I was sitting there down on chair, and well, that's a common problem. What we see. Thank you, Kishore. It was a wonderful program. I've been watching the two. I thought I will somewhere out there, but the program is a wonderful program. And anyway, thanks Anurag and Dr. Rajiv for conceptualizing a fantastic program. I think probably we would have considered a little more time. Probably everybody would have been a little comfortable. It's quite some time, and have a great day, a great night, and good sleep. We will see for the tomorrow's program tomorrow. Thank you very much for all of you.
Thank you, Dr. Malikarjun, and thank you all the panelists and also all the faculty for the whole day. And this was the wonderful program. We exceeded by around 40-45 minutes. And that became unavoidable because of the interest which was generated by this program. We have covered quite a lot. It was not possible to cover everything in one day. And we have the second day tomorrow. And we are starting at 6:25 tomorrow. And it is basically on metastatic carcinoma prostate, and which can be hormone sensitive or castration resistant. And then it will end with the discussion on in the COVID era, what we are doing. So this is going to be very, very interesting program tomorrow. And I think we are all good. And good night for today. Thank you very much, everybody, for ending this on the happy note that all discussed, and audience all remained glued to the all the modes of transmission, that is our Zoom platform, YouTube and Facebook. And more than 500 delegates have registered. This is a huge success. We see you all tomorrow again at 6:25 p.m. Thank you.
Thank you, sir. Good
Thank
night.
you. Thank you, Dr. Sood, sir. Good night. We close the meeting now, sir. Thank you.